when you look at these numbers, sometimes they'll say things, and sometimes that doesn't make any sense. So let's talk about it. Let's really get into this. And does it give a misguided impression? Are there other things that are missing? Because really, knowing what your community is about has to be where this all starts. So I took 3 different assessments to have you have a look at, and I don't think any of them are contradicting any of the others, but they do sort of focus on different kinds of things, and there's certainly some overlap. So the first one is the thing I just handed out. This is a summary of that. So on the left side, this is what that, and by the way, this was done actually, the history of this is that about 5 years ago, the state legislature was about to slash critical access hospitals. We managed to literally save that at the last minute. And then it hasn't been back since. But partly why it wasn't back since is we got together and worked hard on developing the data about every critical access hospital in the state and going and talking to legislators so they understood much more about what was going on. This is the second iteration of this, and it was updated by the Department of Health and the State Hospital Association. So it's the newest generation of that. But that's how this came up in the first place. And as I said, I found a mistake. So if you find mistakes, I'll take them back and get them fixed. So growing population, increasing ethnic diversity, 65%, over 9% and growing of the population is over 65. Relatively high income and low poverty levels, though not consistent across the district. There are pockets of poverty, but if you average it, it's relatively high income, relatively low. I love this one. Less smoking, but more drinking. And by the way, when you look at state averages or census or those issues like you look at this, be careful because it's a trap to think that if you're like the state average and you're equal to or slightly less than the state, you're in good shape. Well, the state isn't in good shape. It's on blood pressure or a number of other things. So if you look at those data, you need to say, is the average good enough for my community? And I think in many cases you'll find it's not. So
was there no comment on drug usage?
Not on. Maybe I just missed that on here. No, there wasn't on this one. There was on the other ones. I think.
That's a serious problem.
Good. Good. I can't write and talk or walk and chew gum at the same time. So can you, questions like that? I really want to make sure we capture them. So would you mind? Is that okay for you? Or I just should have asked you that in advance instead of putting you on the spot. Sorry. Okay, no, that's a really good point. I think I did see it in another one. So then, 116 patients a day, 1% of them are inpatient. 41.4, so this is what's the community, and this is the other side of the sheet, which is what's going on here, at least based on the work that Jody Crowley did with us. 41.4% of the visits are primary care, but that's dropped 12%. 64% is Medicare, and around 7% is Medicaid. Significance there, this is just like almost every other rural hospital in the state. And that's why it's significant, because the business model in a nonprofit or a for-profit hospital in an urban or suburban area is totally different. Business model in those areas is get enough money in profit from private insurance that you can cost shift and save the money that you lose in the public programs. That's the business model. And the second part of the business model is volume. So what are the two things you don't have in rural areas? Private insurance and volume. So when people exactly. So people are talking. That's why Gene mentioned before we started about some bills that are in the legislature and so on. People are beginning to. This is good news because of these pressures and because some people are beginning to think we are at the verge before people start closing hospitals and so on of thinking what would be some ways of financing things that would finance the right things in the right way. We'll get to that.
Again, 64 and plus 7, that's 71.
Yeah.
Does that mean 29% are private pay or charity care?
It means, yes, it means private pay or no pay.
Or no pay.
Right.
And it'd be nice if we could have known what the...
yeah, they didn't have that. That's often hard to get because this is from something called CHARS data, and basically they all call that what do you call it? What do you call it? See, they call it something pay, self-pay or something. That means, no, not self-pay, but it carries that. It's self-pay.
Yeah.
But what also is not in that is commercial.
Yeah, commercial.
Oh, that's what I thought. Okay, yes, of course,
Well, that would
commercial.
be part of what I'm asking.
I thought that's what you said. I thought it's commercial and,
Well, for
Private.
example, when I go to the hospital, I use Medicare plus a lot of private
Yeah.
insurance.
right, that's right. So it's private insurance, self-pay, and charity care.
Yeah.
Okay, ED visits are declining here. Now that's a great example, assuming the data are still true, that that's what it was. It's a great example of is that a good thing or a bad thing? And it's one of those really tough things to deal with because people looking for quick, simple answers won't find them there, especially in rural communities, because often ED becomes the place to do primary care. Well, that's dumb because EDs cost too much as a place to do primary care, but if they're the only place you get access to. So I don't know what's behind that, is my point.
Actually, though, that shows that people are paying attention, because for a while, everybody would come into the emergency room. I mean, Harvard, they would come in with colds or the flu, instead of going to a primary doc, or missing work to go to a primary doc. So if that's declining, then we're doing a good job of educating the
I
public
would agree with that.
of how
That's
to
true.
use
Yeah,
healthcare.
absolutely.
And also hospitals actually have worked together to target reductions in ED.
That's right. That's absolutely right. In fact, that came out, and I wish I started that, I think, 2 or 3 years ago, and it came out because we were in Olympia, and the legislators were about to pass a bill that imposed a whole bunch of stuff on hospitals to do that. And we said, give us a chance to do it without legislation. Yeah, and we did it, and it did make it work. So yeah, good. 8.8% of the commercial inpatient market share. I actually looked at some other market numbers, and this seems high to me, but this is what Jody pulled out, so I don't know what numbers she used. And he looked at a 3-year, and it's on here, a 3-year, that the margin is negative still, and probably always will be without tax dollars, but it's improving over the last, I think it's 3, 5, 1, 3, and 5 years, and it was improving. So that's what I got.
Now, which is improving?
The margin, negative
Commercial?
margin. The margin is better, getting better. It was better than it was.
On
It's
how
still
much is
negative.
being commercial paid?
No, in general, just the bottom line.
We're not a community, we're a community of communities.
Yeah, I think that's right.
And just contrast Carnation with Stonewall Ridge.
Exactly. No, that's right. No, you're absolutely right. And that's where you have to really be, to use a medical metaphor, surgical in the whole process of figuring out how you do that. This is their community health. And yeah, here you go, Chief. Population growth, that was said before. Increased diversity, that was said before. Pockets of wealth and poverty, that was said before. Increasing exposure to marijuana and alcohol. And growing, aging, this kind of gets to your point about pockets, in growing aging population, also growing population with families and kids. So from thinking about it from a healthcare service perspective, you've got 2 different kind of models there of things to relate to.
And poverty, in our case, means shelters in the wintertime. One in Fall City, here in Dr. Valley.
One of my points.
Serious issues. And then they're having tremendous discussion in Fall City about drug abuse. So,
Are we gonna look at this other slide? I have some comments on it.
Well, comment. There they are.
One thing that's not showing there is suicide. We are finding that suicide is becoming more relevant in our kids. And I don't know if it is in the cities, but I know in this community, it certainly has become more relevant. And in Issaquah, they had a suicide, 2 suicides. So I think that's the other thing.
You know, that's a good question to look. We could look into. Maybe you could just tag that because there's something that's done, and some of you will know this. And I can't remember what it's called, but there's schools across the country do a student request
Yes.
every. I think it's 8th grade, 10th grade, and 12th grade, and so on. And it's all self-report. But on something like suicide ideation and so on, it's a pretty good indicator. So it's really
about 2 years ago, we did a community assessment, health assessment.
that's what that's based on.
Yeah, and we did have a higher than state average suicide rate, but it was not broken down between youth and elderly people. So we have a lot of isolated elderly that are committing suicide, even though all of us kind of like to focus on the youth, but there's elderly.
That's absolutely true, because you'll hear medical teams going out to a house, and then the disclosure of what happened is not disclosed. And I'm getting people that come into my office all the time on probate issues, and they tell me, it's people in this community, it's people that are not reported unless it's on the death certificate. That's
Wow.
I didn't know that either. That's kind of unsettling, isn't it? But I do know another factoid that does support it too, though, is that the highest rate of chronic depression is among elderly people. And that's not unrelated to suicide. So, all right. So this is what I thought you'd enjoy. This is just for a little fun. This is what Swedish Issaquah also had to do a community health needs assessment, and those aren't exactly overlapping areas with yours, but there's some overlap, and there's some interesting stuff there. What I think is fascinating about this compared to the other two, which were specifically done for this hospital district, is they were done with their hospital in mind, right? So some of the same issues we talked about in the other two, they come at from an acute care, tertiary care model point of view. So what do they say? And from their own competition perspective. They want to position themselves just as you do, because they want to be sustainable, right? So they want to set themselves up so they can, so look at the questions. I love this. This area, they say, is the increasing percentage that people with, the percentage of people with no health insurance is increasing, and they're 20th of 25 in other King County cities, and I couldn't find the data that said how they compared the cities or what. I think they mean these, they did say Lower Valley and Upper Snoqualmie. So I don't, you guys know your geography better than I do, but, so I don't know if these are exact overlaps or not, but they're looking at this area and they're seeing that there's no health insurance at a rate, they didn't say how much it is, it's probably a relatively low percentage, but compared to other areas in the King County, King County area, that area is 20 to 25. That HIV prevalence is
That means good news. Good news, you're not at the top of that list.
I think it means 25 is bad, is worse.
But you're not 25.
No, it means the number, no, it's not good.
It's not good. Okay.
Yeah, it's not.
Wasn't this taken though before the Obamacare?
The exchange was,
Yes.
it probably was, because the community health needs assessments happened about that same time, so it's hard to know if that's as bad as it was.
But I think it's changed.
You're probably right, that would make sense that it's changed.
Increasing, isn't it?
But some of these things aren't the same as health insurance, like HIV prevalence is increasing, and your, yeah. Right. Later or no, again, the thing to remember is, these are probably really small numbers. So if you get 10 increase of 10, it probably takes you up 5 percentage points. So, you know, but then later or no prenatal is increasing. And again, it's different in Upper Snoqualmie than in Lower Valley. But not appreciably, right. And percentage with no Pap test in 3 years is 9th of 25. That's just better. And low birth weight increasing. Anyway, you can read that. But what you see with all that for me that I thought was fascinating was almost all of that is driving toward their own business model that they're trying to accomplish. So they're thinking about what are the problems in your area that they can solve in a way that helps them strategically.
It looks like 3 out of 7, the big issue is the child and maternal health care.
That would seem like that to me too. I would be flagging that. Especially go back to that other demographic point where you said you got aging and then you got families with kids. So I thought that was kind of fun. Anyway, all right, before I get into this, are there other needs? So what I'm going to do is, so we talk about external environment. Part of the external environment is what's the need in your community. The other part of the external environment is what are the policies and stuff that's going on at the federal and state and local level that will impact what you can do, what you want to do, what you're able to do going forward. So before we switch from the need conversation, what would you underscore or say is all wet, or and maybe even think a little bit about where do you think your number 1 or 2 or 3 needs are that you think are most urgent?
Community Valley here.
Yes, for your community, as Jean says, communities plural.
We also need to recognize that you were showing statistics from our local community. When we look at who we serve, our community actually is much bigger. So we just have to make sure that as we move forward that we're talking about, we're aligning the community with the conversation at hand.
That's a really good distinction, Kim, because for several reasons. For one, accuracy, you're right, but also there's probably a tension there, and not necessarily a bad tension, just one that you need to work through. Your service area is different from your hospital district. And if you don't have a service area that's different from your hospital district, it will have significant financial implications. Which, I mean, in theory, you could say, tough, we're not going to serve anybody except the people in our district, and we'll take the hit. Well, you could do that. That would probably be dumb from a business point of view, but you could do that. So, but I'm saying it does create some interesting things. I worked for Evergreen for about 14 years, and there are always conversations about should the taxpayers of the district get more or less benefit than the other people that aren't the taxpayers, and so on. And I don't think you can ever get off that squirrel wheel, because there's arguments on both sides for doing or not doing that, and it's probably not worth spending a heck of a lot of time on, except what I go to is, what's the both and here? What's the stuff that you need to do for your people in your district, which is most of those other people, that's probably going to help everyone else, so, and probably help your bottom line. So, but you're right, that distinction becomes important as you start thinking, especially if you've got, there are some districts, I don't know, I've not looked at the map recently here, but there are some areas where you have districts that or you have groups that are outside the district that, because of their socioeconomic levels, actually bring a lot into the coffers, but they're not in the district, so you get into real tension in which way you want to go with that. So, other things about needs. Yeah, Chief.
Well,
And then John.
I think among the greatest unmet needs have to do with services to seniors, and I'm thinking specifically about home health care in our district, which it happens to be, as I understand, home health care, maybe that's the fastest growing profession in the United States.
I didn't know that.
And
Doesn't
that's
surprise
a
me.
C-SPAN
Yeah.
program. Hospice, palliative care, and either being able to provide those or maybe closer links with Evergreen and overlay for those services. And right now, essentially, we have no other care, in my opinion. And the only thing we've done is we put nurses in University House and Bellwood and some of the places down there outside of our district. I think we need to focus on the needs in our district.
Well, we could talk about, but I think on a chapter, let's talk about how when we get into discussions later about strategy a little bit, but particularly I want to underscore the first part of your point, which is there are serious needs in our aging population. Probably Gene and I are more sensitive to that than some of the rest of you are, because in our advanced ages, but seriously, there is a need, and in fact, the state acknowledges that. There's the maybe good news, I'm getting ahead of myself a little bit here, but the state has applied for what's called Medicaid Global Waiver Program. We can talk more about that later, but one of the drivers for that, and it's a way to use Medicaid dollars more flexibly, and one of the 2 or 3 drivers of that was just your point, long-term social services, which really means instead of putting people into SNFs, into nursing homes, who don't necessarily need to be there, at least they wouldn't need to be there if there were some other service available to them at lower, for the lower level. So instead we put them in SNFs, which cost more. So they get institutionalized, and it costs more because we don't want to spend the money on home health. And when I ran home health at Evergreen for a while, and home health was, until they got enough volume, it does all right now, but it didn't. It was hard to get enough volume to make it work. So, but if you could do this Medicaid waiver something, in theory, you could begin thinking, instead of thinking it as acute, swing bed, or subacute SNFs, you think of it more as a continuum with home health being there to support and assisted living and so on. So you can use if you could use the money differently. Right now you couldn't do that because you go broke, because there's only things that get paid for that, and that doesn't get paid for.
Okay, now I have a question.
Okay, but Joan was next.
First.
Yes.
Well, I just wanted to say, I was in home health in the hospice for a very long time, well, a long time. But I watched companies go away, and part of Evergreen's success is because several companies left, and where all extended liability, etc., and stuff, because it becomes a separate entity. But on with that. It's hard for
But
me.
before you go, I don't understand. Companies left. I don't know. I just don't know what you're saying.
Companies are gone.
So how there's a high turnover in the, so that was not the home health care business.
Oh, home health companies. Oh, yes. Yes. Oh, yes. Well, that's right. They're actually, because they couldn't make a living, especially ones that were for profit, couldn't make any profit.
Yeah.
And the reason that Evergreen was in it for as long as it did is they used tax dollars to subsidize it. So that's a fact. You're right.
Yeah. Anyway, but when you were asking about needs and whatever, I find it difficult to project. I understand what our needs are, but I find it difficult to project because healthcare and the government are changing just rapid fire, and you may have the best idea of the world.
Yeah, we'll get into that a little bit, and I'll tell you why I'm going to say what I'm about to say, which is with the data a little bit, but I actually don't agree with that. I don't disagree that the world is changing very rapidly. I do disagree that you can't get some pretty good idea of where it's headed. And we'll talk more about that. I think that's a myth that we have allowed us to have to keep us from getting things done. Right, I'd be happy to. I will go through that. Right. Jerry.
It does intrigue me, and actually I'm going to piggyback on what John said. When I was in school, and I went to nursing school, good job, we did visiting nurse. So we did pediatrics and we did seniors, and those are the two things, is that the babies and the young moms and the elderly, that now there's that void there, and it's, why did we throw out a program that was working and met some real specific needs, where we went to them in their home and said, these are the things you can do.
You are completely correct. Carolyn McCall, did you know her? She ran a visiting nurse when I was coming up. She's no longer with us, sadly, but you're exactly right. But you know, if you think about it, it's exactly the problem in healthcare across the board. And I'm talking at the top of Medicare, Medicaid, and so on, which is not 100% certain, but in significant percentages of times, it doesn't incentivize the right things. And it's still the case, maybe we're on the verge of being able to make some changes, but it's still the case, as I said earlier, why do you think more small hospitals aren't doing primary care, observe and transfer linkages things? They're not doing that, and because if they did that starting today, because stop trying to be acute care hospitals in a capital A sense, they'd go bankrupt on Wednesday. And it's not, Roger and I have gone to a number of conferences, and I frankly have gotten tired of listening to people, and we plan Chelan and do that, and I actually have told keynote speakers, to not do this, because it irks me, that's the nicest word, which is that they start guilt tripping hospitals, boards and administrators, because they're not thinking about removing from volume to value and moving to, it's not that they don't think about it, it's that if they did that on Monday, they'd be bankrupt on Thursday, because there's no money for that. Exactly.
And the transition is very slow. That's the problem.
It is, and it's variable too. It's slower at some levels and faster at others. So yes, that's right. There's a guy that was the head of IOM, I think, Institute of Medicine. He said, to your point, Gene, that every system is perfectly designed to create what it creates. So So if you think of, I mean, so it gets you out of the blame game because it's not, A, it's not helpful, but B, it's not true. It's really about people, the best boards and the best administrators will try to do the best thing they can do to maximize their resources, like like a person in gymnastics who wanted to do plastic surgery. And frankly, it's from a health perspective and from a finance perspective, and particularly in rural communities, we're not reimbursing the right things. But that's why people do things that aren't necessarily right. Frankly, it's why you're in swing beds, because swing beds came along in a time when someone said, oh, geez, we could use that and use our beds differently and get a higher rate of reimbursement. So why wouldn't you do it? Well, that's good. One of the things I'm going to talk about is that's probably not going to be there forever. So it's not going to happen day after tomorrow. We're not going to, slash the wrist off. But you need to be thinking, and what's going to be the next thing, which is the main point of the whole day. What are you going to do to help create what that next thing is, so that you are lined up with what the incentives are? And I do think, Joan, that there are some answers to where that
Yeah, and I
is going.
think we will see more and more of those home visits, home health and all
I think
that.
so too.
Because they are promoting, the healthcare industry is promoting aging in place. Most people don't want to go
That's
to a
right.
hospital
That's
or
right.
a nursing home, which is so expensive.
That's
They
right.
would rather stay at their home
Well,
or another
right.
facility that's less.
when I ran hospice at Evergreen for 2 years, and when I came, my first day at Evergreen was the Monday after the Sunday that the inpatient hospice program opened at Evergreen. So I'm very tied into the Evergreen Hospice and so on. And it was fascinating because the business model that was assumed that got that really nice building built that's up there. If you haven't seen it, you should go see it. It's gorgeous and they do a great job. But
Is that the Alva Young building?
no, it does have a name though. There's some other people whose names are on that now, and I forgot who it is. But Al's another one. But anyway, soon after, within a couple of years after they opened that, and the business model was great, right? Because it was inpatient hospice. We were going to make money on this inpatient, and it was also going to be doing great things for the community, and it was a gorgeous facility, right? Well, about 2 or 3 years after they opened it, Medicare hospice benefit changed, and it made it so it was almost impossible to get reimbursed for an inpatient hospice visit. It would have to almost all be outpatient. But guess what? Nobody wanted to be inpatient. I mean, there's this beautiful facility. I don't know why wouldn't you want to go to the facility? That their census went up several 100% when they just started doing everything at home. So it reinforces the point that it's not always, the fact that the financing change isn't always.
And also, the long-term care insurance doesn't necessarily change that problem. For example, in my case, I had $70,000 invested in a long-term care policy for my wife. She didn't want to go. She wanted me to take care of her. And so at the very last, I started using a little home health care. But basically, it was an issue that people want to stay at home.
Exactly.
And that's what I want to piggyback on. It used to be families lived closer together, lived together longer, they ran the farm, the kids took care of mom. I mean, it's the old, what was that TV show with the family that had the
Brady
Waltons?
Bunch.
The Waltons, grandma was in the house and the matriarch and everything. So our culture has changed and the science has become so much better that it's difficult because if your kid's in that east and you're sitting here getting old and needing help, there's nobody there to help you.
No, there's no question it's changed. There's no question in so many ways, not just healthcare.
Yeah.
We haven't figured out the processes and systems to catch up with the demographic and electronic and other changes. But how many of you were at the WISHA annual meeting this last year? You were there.
I went to part of it. Yeah.
Well, there was a woman who's a pediatrician at Children's, Seattle Children's, and she got up and spoke, and it relates to your point, Daryl, because first of all, she put a 2-hour presentation in 15 minutes. Even I, as fast as I talk, couldn't keep up with her. I mean, she was just going about 100 miles an hour. You come out and go, who was that Matt Smith? But anyway, she said what she essentially said was, thinking about the tools that we have around available to us that we haven't really put to use yet, there are ways to now begin to respond to the changed social environment that you just talked about. So you talked about a number of ways to do that. It'd be worth actually going online and looking at that. I think it's videotaped on Bush's website, but fascinating. All right, let's move on. It's good discussion though, let's keep it up. So this is, first we're going to talk about DC. I know everybody's favorite topic.
My husband's there right now.
Is that right?
Yeah, he's in DC.
And does Riker, is he in this,
Yes.
Riker, this is a very important point that you should all keep track of here. So, it's the doc fix bill, and all of a sudden I can't remember the name of it. Sustainable Growth Resolution in March happened, and the doc fix happened, and it changed the whole way in which we're thinking about funding for docs going forward. But we'll get into that in a minute. But the key here to this slide is don't expect much congressional action, good or bad congressional action, this year.
Yeah, we only work 3 days a week.
Well,
Expect them.
111 days, which is even less than usual, and it's probably less than that because of things that aren't really working but get counted there. No, you're quite right. But as it says, most of the legislative activity will happen before July 15th, because then they'll be adjourned to campaign basically for the elections. And add to that the Republicans have the majority of both houses, and so they're not going to do anything too controversial because they want to retain their majority. The corollary to that, by the way, is the Democrats will do everything they can to make them have to make decisions that are politically untenable, so that, for the same reasons. But that's the nature of the world up there. And back on the top, in addition to the bills, that one big bill, the doc fix was passed. The omnibus appropriations bill was also passed. So there's really no urgent, like the last few years, there were these looming deadlines that they had to have resolved by March or September or November or whatever. We don't have those this year.
Not for that, right?
Correct.
Yeah. Then what was your point about J. Harper?
Oh, I'll get to that.
Oh, okay.
I'll get to that. So the SGR mix replaced SGR with MACRA, which I can tell you what MACRA stands for. Does anybody else know what MACRA stands for? Do you?
Medical, it has to do with the physicians, and children.
Oh, that's great. You
Yeah.
do. Yes, that's right.
Yeah.
I didn't know what it
Children,
was.
yeah.
It's the Medicare Access
Medicare
and
Access.
CHIP, which is the
CHIP,
Children's
yeah.
Reconciliation Act.
Reconciliation Act.
And you'll never have to know that again. I just felt like I had to say that and have you know that I knew what it was. And what that does is it bases docs payment on the quality or on their participation in alternative payment methods like ACOs. So it's instead of the basis that it used before, it moves like so many things. Now here's an example, John, of what I'm talking about. This is one thing where you can't say there's a law X that's passed and now we're going to do these things. But this was one of the many little rivulets driving toward quality defined value, which gets defined mostly by quality indicators, based services being the driver as opposed to volume or as opposed to type of diagnosis and so on. So that's one that you know. So if you're thinking as a board, what's one of the true north stars I'm going to have to look at? I'm going to flag that one. That's one.
MACRA.
No, the idea of the doc payments moving to quality or participation in alternative payment.
Look at the slowness of this process. They don't even begin data collection until 2017,
That's right.
and then 2018.
I know.
But
But
this bundled payment deal, it was supposed to start first of the
I
year,
know.
and it's in April,
I
and
know.
it just drags out forever.
Well, there's two ways. There's that glasses half full, glasses half empty part to that, Gene. It's slow as hell, and it's not synchronized, and that, by the way, is the U.S. government in a nutshell. But it's also because of exactly what you said. There's actually time, if you're thinking creatively and you're working collectively with other folks, to begin turning the battleship around. So you're not wrong, but that taking too long issue. Frankly, the only thing I can think of worse than taking as long as they have is taking less long, because I don't trust they would do it very well. So But anyway, that's one thing. So, other thoughts about this? Yeah, Roger.
Potentially, there's a lot of unintended consequences with that, and so,
Right.
if it's more deliberate and we test it as we go,
Right.
it's a better outcome.
Absolutely, and you take a page out of lean stuff and all those things. There's not very much of that cerebral conversation that's going on that actually talks to people like you that are in the trenches, knowing what the hell it looks like down here. So, I mean, even stuff we've done in Olympia already last year, this year, and previous years, is often stuff that looks pretty good at 150 feet, 150,000 feet. But when it gets down to how does it actually work with small with small populations, it doesn't work. So you're right. When you can test that, that's why pilot projects and things like that are a good idea. And by the way, we're trying to get some of those going. So anyway.
Do you see a problem with the dichotomy between the speed of medical research and changes in the medical profession and the administrative and reimbursement side of things that we're talking about here?
I don't entirely.
There's speed on the one side with
medicine,
changes,
yeah,
and yet the slowness of the adjustments from administratively and regards to reimbursement.
Yeah, I think there's some tension there. I think it's clearly tension. But again, that tension will have some negative effects. People will rush too quickly on some things and not quickly enough on others. It also could have some positive effects in terms of, one time somebody defined creativity as taking two opposite, finding something that could make two things that seem opposite actually coexist. So when you start trying to think about how do you get quality, but how do you still have docs get reimbursed, but I think you raise another issue that's not in here, and Jim could probably talk to this, but the whole issue around docs, not just the supply of docs, but docs' satisfaction with their work, docs. And part of that, it gets written off to a number of things, and it's easy to oversimplify. I actually think, at least in a macro way, it really is the same thing you're talking about. It's the fact that change is happening so fast, nobody really knows what their job's going to be, and so on. And sometimes, and I have a sister-in-law who's a doctor at the Olympic Medical Center, and she came out, she's about my age, a little younger, she came out with sort of going to be the doc in a small primary care practice and do all this stuff. And she loves it, and she's a great doc. And she's now we talked to her about her work, and she looks like Eeyore. I mean, she's like,
yeah.
And it's like, and I know in Eugene, docs are actually organizing labor union. And I just think that if I were talking to pinpoint one issue in the macro arena, and I don't think, and by the way, some of it, again, a response, not mine, I'm talking like I'm a doctor, but one of the issues is what I said at the outset of this meeting, which is thwarted expectations. I said, because this woman, the children's doc that I told you spoke at the WISH annual meeting, she was in a sense that the millennial almost, maybe she's Gen X probably, she looked like she was millennial, but the Gen X version of my sister-in-law. She was this young woman doctor that was dynamic and going to go do great things. And here's the great irony. She was talking about the very things that are driving my sister-in-law nuts. The very things she was saying were going to save us and help give patients connections and all that, like electronics, stuff like all that, was the very stuff that my sister-in-law says when the IT guy says, when they were going to Epic, and he said, look, all you have to do when that happens is click here. She said, she's not like this kind of person, but she said, she told me, she said to him, no, I'm not going to click right there. I'm going to call you. This is not my job to click right there. So
Yeah,
here's my sister-in-law, and here's this woman speaking. So I think a lot of it is just that generational shift and
No, absolutely. I mean, the physician burnout is a real thing right now, and it is we have two cultures that are clashing. The older and the younger generation, which is not new, but the burnout is not only the workload of day to day. That workload doesn't meet expectations from when they came into the industry, but also it's not so much the burden that's on them right now, but it's the emotional burden, the lack of hope because they're not able to see.
Well said.
They're not able to see in the future, so there's nothing fueling them.
And that's resulted in docs bailing out.
It is.
The whole
That's
system,
not the only.
retiring early, and especially primary care doctors, where the need is greatest and we have the greatest deficit.
I think that's right. Go ahead.
I think the other thing too is liability. and we haven't talked about that at all, that, you know, when you go to school, you spend that time and you become so liable for everything you say and do from a professional point of view. And somebody wants the house, the car, the kid, and everything. That's a huge burden to always be thinking, I cannot make a mistake ever. And mistakes happen. So for me, the expectations of docs is huge. We expect them to be God, and they are not, they are human. And that, particularly in the US, even though we're trying to be more socialized, that's something we haven't given up. And I think, to me, that's a real, that's the thorn that is still there, that's not being addressed at all. It's just kind of like not even out there, and I
Well,
think it's a
yeah,
legitimate thorn.
to follow on my comment to Joe, I wouldn't say that it's not being addressed.
Okay.
It is being addressed, whether it's being addressed, and I would even say it's being addressed correctly. Whether it's happening fast enough, to Gene's point, to address the situation is, I don't know. And it may just have to be a generational change and so on. But, for example, one of the big things that I've on my board is that we're actively working with the WSU, and I'm a Husky, I'm 7 years as a Husky.
Well, what are you doing over
I know,
there?
I know. I know, but it's for the greater good. I'm working with them on, they've got a whole community-based medical education with their new brand new medical school, and their whole model is working with docs like him in the community as, not to link up with them, but they become the faculty. And for two reasons. One is they then are actually practicing in the real world, that's his 3rd and 4th year medical school, but they're also much more likely to stay in a rural community when they do it. So that's one thing that's happening. Other things that's happening, and this is partly hard because the family practice docs group isn't so opposed to this, but WISMA sort of is, and that's the whole idea of when do you use PAs? When do you use ARPs? What are the things to do that? And that's all working itself out, and that's tough. And I'm not any quick answers there, but it's working itself out. So,
Okay,
yeah.
good to hear.
Yeah. But at least you know something. It's kind of like the point about value and quality, is you know that if it isn't like we could turn anywhere and not know which way to go. No, you kind of know that's got it. Why do you know that? Because if you think the hospital may not be sustainable, healthcare is not sustainable.
Yeah.
You know that the cost of healthcare in this state, in this country, is equal to the GDP of Great Britain. And while the growth rate slowed in the last couple of years, owing in large part to the fact that the economy didn't grow at a very rapid rate at all, it's still growing.
Yeah.
So. Okay, well, this is why I don't think it's all about, that's why there are people, I go to Eastern Washington, a lot of people think it's all about, quote, Obamacare. If we just didn't have Obamacare. And I said, you know what, if the Republicans had come in and tried to do something, they would have been confronted with the same problem. The same problem has nothing to do with politics. It has to do with demographics, we're getting older, and economics. It's costing us too much. So, all right. So the budget was passed, and this is another interesting thing. They put spending caps. This is Boehner's gift before he stopped being speaker. This is the budget they passed that he literally did on his last day before he left. That spending cap for fiscal year 16 and fiscal year 17 are split evenly between domestic and national security programs. So that's a spending cap. Medicare and Medicaid are exempt, so that's good news, because if you're going to get Medicare, Medicaid, which 71% of your business is, but other programs like Flex, Workforce Development, and all these other things that are going to help facilitate the things you're talking about are subject to the caps. So if they reach those caps, then they're going to start cutting half on military, half on domestic, and that's going to be where there's going to be some hits.
Also, we don't have an approved presidential budget, we have a continuation budget.
Yeah.
And so some of the issues in the Department of Health and Human Services budget cannot go into effect.
Yeah, but the presidential budget in this Congress is a little bit like my high school paper on, it's sort of somewhere in the bottom of the bookcase, because with the Congress having the majority it does, the president budget isn't anything except potentially a political document. And by the way, that cuts both ways, depending on, not to not be partisan here, because it's just a fact of life that when you've got a majority of one party in both houses of Congress, and you've got the president as a different person, then when he writes the budget, he knows it's not going anywhere, so he puts things in that are going to be political. And when he writes it, they know it's not going to go anywhere, so that's a game.
But remember, this can change with the election.
It certainly can. That's right. That's true. So site neutral payments. Do you guys know what that's about?
No.
I don't know, Roger, if you guys do this, Steve, but there are a number of rural that have rural health clinics that are that are part of their. I'll just explain what it is that quickly so people want to talk about. That are part of their hospital system, part of their hospital district. And there's been and historically, a lot of the docs and communities have wanted to join their clinics with the hospitals because they can't make it on what they get paid. And the reason they can make it if they join with the hospitals is that the hospitals get both the physician amount and the facility amount. And when you put it together, they can about break even, right? So for some of us, that sounds like pretty good thinking, right? Because you're putting it together, you're making it working closely together. So by the way, 70% of the clinics in rural areas in this state are aligned with rural hospitals. Most of them are public hospital districts, in fact, all but 2. So anyway, so there's that. So this is decided that that there should be no, as of 1/1/17, there should be no facility fee in provider-based clinics. Now the good news is it doesn't affect the rural health clinics, which is those in smaller areas. So that's going to let most of our guys off the hook. But the concept in general is there. So at some point you need to keep your eye on that. And maybe you don't promote so much because you have those kind of clinics, but if you ever wanted to get into that business, and then it only impacts those clinics that are linked with hospitals that start after when the bill was passed, which was 11/2.
So we do have provider-based clinics, we don't have rural.
We don't have rural.
We do have provider-based clinics. So we will still, we'll still be under the obligation.
I think so. It would be bear looking into somewhere. I don't know, maybe Roger, but as I read this, they're going to be they're trying to fix this in the agenda. What they're trying to do here is work it so that they delay that input, but I don't know if it affects you or not. I don't know more about how you structure it. So
We are obligated right now to do facility for Medicare, Railroad, and TRICARE.
well, it's worth checking out because it could be an issue. So this is what's on the American Hospital Association, and therefore the large extent our agenda. I should say, some of you know, some of you don't, but about 3 years ago, 15, 20 years ago, Washington Hospital Association had a federal person on staff. They ended up thinking that was really more of AHA's issue, and they really couldn't afford it. But things have gotten so strange that in the last, probably 2 years ago now, State Hospital Association joined with the Oregon Hospital Association to hire a guy that was the chief staff person for Max Bacchus in Montana, who knows all about rural and all about elder issues. And so this guy, his name is John Flink, is now our connection. And so we really do have a link there. And he's actually already had some impact. There was a bill that one of the issues for the number of, are you guys in the ACO? That state. There's a number of rural hospitals that are part of a state nationwide accountable care organization, and those and what they found out was that the language, the statute for reimbursing them would reimburse docs for certain things, but wouldn't reimburse PAs or ARNPs for doing things that were really, and nobody intended it, even the docs didn't expect it, but it raised their costs significantly and made them not viable. So they were able to use whatever they wanted. So that change was made. So the 96-hour fix, a link to stay fix. Do anybody know what that is?
Well, this means what?
Link to stay. Length of stay.
Length of stay.
Length of stay. Time that you have a patient in the
Length.
hospital. Length. Length.
Of the stay.
And what that means is that in the critical access hospital conditions of participation, now listen carefully, it says that you can have 96 hours on average of patients for a year, right? In acute status, right, exactly, thank you. The new interpretation, which has actually been on the books forever but hasn't been enforced, is that the Medicare conditions of payment will be enforced to say that you can't, no one patient can be there for more than 96 hours. And that the physician has to certify that they won't be, but if the physician doesn't certify that, or the physician certifies that they will be out at 96 hours and they stay longer, you don't get paid.
Oh, that's,
How does that impact swing bed? It does not swing.
I don't think it does particularly. You guys are, you would know the answer better than I will, but I don't think it does. It's more just for the acute care. It's a serious issue for Medicare acute care patients. Well, no, it's not been fixed at all, but we're gonna go into, we're gonna, yeah, we're gonna, that's why it's on the agenda. We're gonna try to align it so that it's all like the first, like the conditions of participation, that it's an average acute for the year, which I think is fine. No one's really had a problem with that, but that's what that's about.
And I have the same approach for acute care, the Cinderella rule, so before you 8 hours, you have to certify one way or another, and it's and it started just about 2 years ago. That was disastrous.
Yeah. Oh, yeah.
Totally disastrous.
You know, when I was working in hospice, they still do this, I think it's relaxed somewhat. In order to be eligible for the hospice benefit, the doc had to certify that you were gonna die in less than 6 months. Seriously? I haven't seen any doc who would, it's the same still?
It's the same. You still have to certify that their expected length of life is less than 6 months. And you recertify that
Every 6 months. I think that's what changed. I don't think you got to recertify before. So anyway.
That's the other language.
So anyway,
Ben,
yeah.
there's another game that we play, and that is the 3-day stay rule. And is there any talk about changing that? Because everybody knows how to play the game. You've got to have 3 midnights in a
Oh, right. There is, and I should have put that up there, the 3 midnight rule, and I can't remember it. I don't want to misinform you, but I can get back to you on the details.
I think under the bundle for hits and boots.
Right.
That for patients who are going to a skilled nursing facility that carries a 3 or more star rating on Medicare site for quality of the nursing home, that they will waive the 3-day rule on those patients under the bundle payment program.
And some of the Medicare Advantage plans are regulated in their policies that, to do the 3 minutes stay.
You clearly know. I need to get educated on that. I know that it was an issue, but I'm not current. And I didn't know this. My wife's the State Mental Health Association CEO, and she would be embarrassed that I had to tell you this, but I didn't know what that was until I read it in the federal notes. But apparently there's a prohibition. I'm pretty sure what it relates to is institutional beds. So in other words, when Medicaid moved some years ago, moved patients out of mental hospitals and started paying for community services for mental health, they have a limit, and I think it's 16 people that can be in a facility and still get paid. If it's any bigger than that, then because their thinking is they don't want to be paying for all those people that are in the community, but it's a bad idea. So the point is, if there are hospitals now, and we know right now that especially with Western State being the mess that it's in, Cassie just had a call this week with a bunch of hospitals about bigger ones, about whether they would be able or interested in housing more mentally ill people, because obviously it isn't just using up spare beds. You need different staffing, you need different structure, you need different, and some were, but it's a big thing. But right now, Medicaid won't pay for those institutional beds. They pay for community, and they'll pay for some institutional in these units that are up to 16 beds, and they'll pay if you are a danger to yourself or others in Western State if there were beds there, but there aren't. So if you guys, it relates to the boarding issue that you all read about and how we're not supposed to board, but if you decided and you got some state funding to support actually doing this, it's probably not anything you're probably going to do, but just so you know what that is. So we're going to try to relax that prohibition. This is something you might be thinking about. And from in terms of mental health, telepsych, there are a number of people doing some interesting things with that. And wish it passing the bill that allows for telemedicine to be reimbursed. There's a lot more work to be done, not necessarily legislative, but if you got into Medicare and Medicaid laws that would encourage that and provide some incentives, that would be a useful thing.
Do you think telepsych would be something that our hospitals should consider?
I would put it on the list of things to review. I don't know anything much about, but looking at those needs that we talked about earlier, and talking about elderly and depression, and talking about the proximity you are to other places, I'm not saying yes or no, but I would say if I were thinking about something that the world is changing, I'm going to tell you more about this later, but there's a hospital in Davenport that is a lot like and a lot different from you. Roger knows all about them, but they're alike in the sense that they transformed themselves into being an organization that links with other folks, and they use robotics, not telepsych, but other kind of robotics, to do a lot of that. And I'll talk more about that later, but I do think you should think about it. I mean,
we employ a full-time psychiatrist.
I didn't know that. So, so I don't know
There's
what.
so much energy coming from the president now about mental health. I can't help but think there's going to be some money that follows.
I think that's right, and I think it's because it's not just coming from the president; it's coming from all corners.
Yeah.
Because the people that don't want you to mess with their guns are putting all that into the mental health arena too. So, I mean, so politically, if you can see something that's coming from 2 or 3 different sources, you could, if you were a betting man, you might want to bet on that. So, all right, good. Oh, this is important, and also pricing. We're actually doing at the state level that WISH is doing a bill to actually provide loan forgiveness for mental health professionals who choose. It's not just for rural, but it will help in rural areas. So this is last 2 things. Health information technology. I don't know where you are on meaningful use. I didn't ask 2. They're talking about trying to get a delay on stage 3 for a year, and it's not been. There's nobody. They're not interested in trying to delay it yet, but they're working. AHA is working on that. Interoperability legislation. That's Senator Patty Murray is really working. And I've got something to give you on that, and you just want to read up on it. I don't have all the details of it, but just to tell you something about it. But the whole idea is to try to get yes, to get yes, one system to be able to talk to each other and make it and provide some money for making that happen, right? And I mentioned the 96-hour rule earlier. I mentioned the 96-hour rule, and that's a little bit more about that. So, and then we're working with Senator Cantwell on more residency slots for docs in rural areas, and funding for nurses and other health professional training. So that's the agenda at the federal level. Now just a minute about bundled payments, and I think you guys probably know a lot more about this than I do, but as I said earlier, major metropolitan areas, including Seattle, must participate in this bundle where it's hips and knees, and you have to do everything from get a lump sum for the service from the initial physician visit to rehab in a SNF or swing bed, and the entity that gets that is the major provider, and then they have to decide how they're going to spend the money. I happened to look, Roger and I talked a little bit about this a couple months ago, and so I happened to look at, got Andrew to pull some numbers from the New York system that showed that Swedish Issaquah, Evergreen, and Overlake, and they're bundling their margin, their lids. 2 of those are well under, and 1 of them's not. It's quite over, meaning if you took all their bundles and you added up what it cost over the last year, and you set a level that they do, the feds do, then who's under it and who's over it? One of them is well over. What does that mean, huh?
Would you tell us?
Any guesses? I'll tell you, okay, because it's hard data. So what's the over?
What would you say? What would you say? What would you say?
Swedish.
Is that a cost or charges? Oh, of course, it's charges.
Charges,
Right.
okay.
Yeah.
Right.
So those,
Yeah.
they told us the
Charlie
charges.
might just real quickly give, we did some research on it, you guys did some research on this, the impact it won't have on us.
Yeah, by all means.
Yeah, so we took a look at the program and which patients are likely to be more directed. And these are the patients, when you take a look at that 3-day rule and that 3-day rule goes away, well, they're going to be pushing more patients actually out into SNF, and they're going to be directing them. But there are a lot of patients in that cohort that can't go to a SNF, and
Because it's not high enough care.
because they don't have a high enough level of care. That we already are that niche for those patients, and we're right now seeing the patients who have had a 3-day stay or longer, right? I mean, that's just the way it's been structured already. Those patients are not the patients that are going to be headed to a SNF that the bundled payment recipient has negotiated some kind of lower rate.
Well, I'd love to see that. You're more optimistic. Here's what I think the pressure will be. I shouldn't say this back home. We can't tell the folks back up downtown at Bush offices. I said this, but if I were way over the margin, I would be finding ways to rationalize sending them to SNFs. Now, the point's well taken that they can't. Some of them can't go there.
No,
But
they will, but
they'll try.
Is the portion of, there are a lot of hits and needs out there.
Exactly.
We're not seeing them
Yes.
in large quantity.
That was the statistic that I was thinking about just on diagnosis 469.
Very low
Really?
numbers that we're getting, and the ones that we are getting are really, really sick.
I only had 3 in the last.
Yeah.
Okay.
It's very low numbers. So,
But high acuity.
but high acuity, there's a lot of patients out there getting hits and needs. Well, what's happening to them? Well, they're discharging from the hospital the day after surgery, or 2 days after surgery. We never even see a referral for them.
Who's gonna pay for them if they come to our swing bed program?
They won't come to us.
They won't.
They're not, because they're being
Yeah.
discharged at home.
They're
That's what's happening.
They're
Yeah.
discharging on, right today, aside from this bundle payment program, they're already discharging home. Or in some cases, patients who have satisfied the 3-day stay and aren't really so sick that a SNF can't handle them, they do go to skilled nursing facilities, but we're not seeing those patients. So the ones that are going to get redirected because there's now an incentive related to the bundle payment program is a subset of this, which is between us and going home.
Right.
And it's the skilled nursing facilities who I think are running for the hills or trying to figure out how to align themselves with get into a preferred status. The other overlay on all of this is that the hospitals only have the ability, and this is in the legislation, they only have the ability to persuade. They cannot direct.
Oh, yes, I know, that's right.
Right? So
Right,
the
although,
patient continues to have their choice.
yeah, although there's a lot of, there's a number of places in the law that are like that, and what nurses and discharge people have done frequently is, here are 3 options.
We know, yeah, that's absolutely true. Again, and I see that for this program today, that's going to be a challenge for those skilled nursing facilities that are getting those patients in between us and home and discharge home. But it is a forebearer of other things to come.
Well, that's a really important point as you're thinking and to write down as a theme, because and I know there's been talk about, and some of you have heard it, about whether swing beds are going to be with us forever and how much you should rely on that and so on. I would just tell you it's the same thing as the whole question of critical access. I think that probably sometime in 5, 6, 8 years, there will probably be some changing of that, along with the changing of the whole value stuff and the whole broadening of the continuum and so on. There's no proposal out there right now, no formal proposal in the Republicans or the Democrats or anybody. The OIG has thrown out something which you might have read because they throw out stuff all the time.
Yeah, which
is dead on arrival.
Slapped them down.
Exactly, that's exactly right. And that's right. In fact, they actually wrote back to this.
Well, they did.
That's right.
So let them have it.
That's
They
right.
said your data's bad.
That's right.
Stop doing it.
So I think that there is certainly, I think, some reason to think in the future that your point earlier about home health and how things are going to, that this will all play into that conversation. But I don't think it's one of those, oh my God, kind of things. So, and especially given what he said, because there's some ways you can use that. That's what I heard Tom saying. I mean, that this isn't all bad. For you.
Oh, on the bundle payment?
Yeah. So it's not, I don't know what you're thinking, the bottom line, if it's a net positive or negative or about the same.
I don't see it. I don't see, on this program itself, I don't see it impacting our census at all. But what's gonna happen is CMS is gonna learn a lot
Yes.
about how they can change behaviors by changing the way that they pay. So again, it'll be a lessons learned.
Yep.
And this thing is a 5-year, this is a 5-year class that CMS is imposing on us. And at the end of 5 years, you're gonna say, okay, what did we learn from bundle fits and needs? And they'll be bundling more.
Yeah, but let's be clear about what we're saying about bundling, and that is hip replacement, the whole surgical experience in the hospital is bundled with the aftercare.
Pre and post.
Yes, and if the hospital finds that it's been referring to a skilled nursing facility or other facility that's too expensive, it will affect their picture as a hospital.
Correct.
And they will find ways not to refer there.
Well, yes and no. You're right in principle, but there's more to it than that. That's a little, which is his point, I think, which is that yes, for those people for whom there's an option to send them to a less acute environment. But the other way, glass is half full part of that is you happen to be one of the only shows in town that can work with the more acute ones that the SNFs can't work with. So you got to look at both sides of that coin. I'm not arguing with you, but it's both halves, right?
The cost of a readmission from a failed discharge.
Right.
It
Very good.
is rapidly escalating at some level.
And that's another incentive for them to spend a little more on the bundle here if it's going to reduce the chance of a discharge, a readmission.
I'm really glad that Dr. Wickham brought up the readmission rate, because we have been searching for that number ourselves for a long time, trying to get a very firm fix on it, because it's a way that we represent value.
Right.
And what we've come to conclude, we've talked to consultants, we've tried tracking it internally, and it's really tough to get at. The place where you get that data is from CMS, and its availability is within your membership of an ACO. So if there are a lot of reasons to join an ACO, but I'll tell you one of the top for me is that now we get CMS data that helps us show what our value is specifically to this point, and that is that we keep patients from being
Tom, that's exactly what I would say the brightest leaders in rural healthcare in the state have come to the same conclusion. I know you're part of the Western Rural Health Collaborative. Some of the people that are involved down there, I talked to Eric Moll about this initially. I was sort of naive and thought, well, why is everybody jumping on the ACO thing? Because frankly, the data don't look that great. And he and Renee and others have said quite clearly they're doing it to get the data and to practice what it means to be working in a value-based environment. So you're exactly right. All right. So I think we've done all that to death. Let's see what's next. I think it might be time for a biology break. Yes. Do you want to take a break and then we'll come back and separate
I'd like to
minutes?
see us at some point take a break, whether now or.
Well, I didn't do an agenda, so if you guys don't need this, we can wait. But I'm a little older.
This is a good time to do it, I think.
Okay, yeah. Oh, we'll come back I'll come back at 10 to 3. Thanks for doing that.
Oh, no,
Okay. Actually, I'm just 1 degree, so I just.
That's interesting.
Yeah.
Oh, you've been.
1 degree.
And it was too warm and now it's cold.
It's easy to get. It's you. It's you.
Like 2 or 3.
I was a little chilly myself.
Well, it was so warm when we got here.
I posted in the room, I wanted to go get it.
Yes, I know. Take it out, just don't. Yeah.
Where's the paper? Another 5 degrees.
That's exactly. That's right. That's what your Medicare benefit is. That's right, that's right. But that doesn't mean, but, number one, clear to me that the world has changed. And I don't
Oh,
know
look at you now.
conversation you guys have had, and what you guys have had with, long-term.
You're
care
drama.
people in Olympia, and also with, with Evergreen. Right, that's what I mean, we're guiding them to do that, but I mean, you might explore that, and have them explore.
Are you, well, you can.
Because they have a
Did you get
pretty system
Wi-Fi?
there, and in the next year.
There may be some of the things
It's cheap. So the latest elements and
Yeah, that's also.
exactly, right, I know.
Yeah, I guess you're right.
Anyway,
I'm just trying to get more complete for you.
I think that's what.
Yes.
How you doing? Oh, no, here they all come now.
Yeah.
There was a line of committee yesterday.
Well, I'm seeing-
I didn't know they had a line of committee yesterday. You never.
I didn't know that. I thought, oh, so that makes 2 of us.
Oh, that's right.
Hey, Scott, what is that?
I said, Marie, the young lady I used to, that she was, Marie, or one of them was Michi, yes, how is she? She's just in college now and doing, yeah. Oh. But she finished, yeah, that's what she was up to. Wow. And she hasn't been back for a bit.
This was kind of like one of the more advanced things.
Years. Oh, and then
All the kids
how many students are getting? So 600 years. Oh, you're getting a lot of students.
There are some lessons or Spanish language classes, it's just teachers.
Right, yeah. I remember before I left, there was another, the mayor of Chacabucayo moved to another town. And I think at one time, one to town, this was town. That didn't work out. And 2 in 1. Yeah, yeah, that's probably good.
That's what I mean, so whatever you.
Yeah,
do,
yeah, yeah, yeah.
Just young guys, do it, and.
Oh, good, good, yeah. Oh, that's wonderful, that they're,
On the website, you see
oh, you know,
dance.
and pictures, yeah. Oh, wonderful. Yeah, you're so, like, with the painting and, yeah, yeah, that's wonderful. She's still going to, Peru.
Well, anyway, I think
Have you been on the name? They were taking the Sister City also. Oh. Is it part of the Sister City? Take it on the board? Oh, yeah, yeah, sure. Lady, yeah, oh, how much is that gonna be? Wow. The reclamation of the hospital. You've been in they're out there, so obviously.
Okay, good.
Yeah, yeah. But I think we are so much of it, much of it, she likes that, yeah, that's very fun too. Have you been to Birmingham?
Exactly. Turned up the heat incrementally.
Oh, I thought you wanted to know about the hospital.
And then you had a hospice.
My
program for the
neighbor.
frogs, right?
No, we didn't.
Exactly.
But I was that very hazard took 2 weeks to go through the they didn't know anybody there.
Yeah, that's good. I think I can think of ways.
And they would no family, they don't know anybody. This is like one time that seems to be very organized and very horrible. Costa Rica, yes, yeah, that's a good one. Many of my husbands are retired police officers. That's why they retired, because there's no, obviously, there's no. I don't, they don't have no, they're very, peaceful, peaceful.
The guy used to
With
run,
no guns or anything like that.
Oh, that's it.
Thank you.
No revolution. Costa Rica is a very,
Yeah, they are good.
That's what a lot of my, retired.
Like that, that's very good.
I have to.
That's quite nice.
Yeah.
But no, it's
You
really.
make reservations.
It's nice, it's the only country, I mean, it's because of its similarities from and again, the government. And you get something like that. Yeah. Yeah, they have a place, they regard that, you know, that little picture they give you.
Oh, that I don't know.
Yeah.
All right.
no, I mean, it's gonna be
That's right.
a little higher now.
But it's good.
But it's good, and
One of my
people are
first
there. Any kind of
organizations working with organizations that involve students, so they
Really?
go through. Because they find
Well, then, the competition is like across the street, and brains is just.
Who's got the stuff?
Do you live?
The Tulsa Beast.
That's,
But he used to be, but the owner of
yeah,
that
yeah.
is maybe that name,
Right, and then.
That's right, yeah, yeah, right.
That's what it is. Yeah, not just another one.
Yeah. No, I think it's
Yeah.
different. I think
Yeah.
Which is that.
You gotta go to the rest of this place, the other half of the-
It's very deceiving, yeah. The outside nice, like mine.
That's why I said,
That's what it is. Good experience.
Yeah, right.
From the outside, you would.
Right.
It's good stuff.
I actually have a real underground. Mediterranean restaurant on the way. To the north edge of Duval, and it's the first place, but it has Hispanic computer, Zaz, you know,
Yeah.
Zaz.
What do you think? That's right.
Hispanic computer.
On the Yelp, the reviews are really good.
We gotta just do one more.
Well, we got
It's like the
We got a cake, and that's.
That's one of the bases.
That's a good one.
Good discussion, good. Yeah.
Okay, you know,
True.
Absolutely. That's right. And we're all obsessed with this particularly. Not to just go to our back, but just to see reactions at first.
I'm thinking about.
well,
Yeah.
Exactly. So, right, that's true, and I didn't put all that down. That just hurt.
well, but something I noticed.
I was like, he looks familiar, but I can't.
That's a good idea. I'm gonna.
But if you told me you said it was his birthday today, I might have gotten. Oh.
That's why.
Just beyond the elevator.
Well, I was there, and maybe.
Just go up on the other side.
Yeah.
Call,
Every 3 months.
Good for you. I don't know, do we have a provision for people that are concerned about inpatients? Oh, sure. No, we take it started. Put them up somewhere. Okay, good, yeah. I've not seen it. Yeah. Wow, yeah. Oh, hey, yeah, you have a card.
I bet you. I even thought to stick some in my pocket.
So maybe others would like that.
Yeah.
Okay.
I need it first. All right, well, then we'll try this other
They're
one.
working on it, they slowly, it's an accident process.
Sure.
Anyway.
That works.
Oh,
Wanting to stay and
So we actually see what happens in classes. Yeah.
Welcome back. You guys are pretty compliant. You must be in healthcare.
Actually, you haven't seen us as patients.
Yeah, it's true. What's that say? Doctors make terrible patients, isn't that what they say? Yeah.
And I can attest, I've had
Nurses
nurses, doctors,
too.
and patients.
My contact information is on the last slide, and we're gonna hand out all these slides to you, so you can get it there, but here's my card too, if you want it, so Roger always knows how to get a hold of me, though, and calls me with the computer.
I know where the webpage is.
All right, so anyway.
Thank you. Did you want the rest of these then?
Yes, please, I'll keep them back.
They're out there by the, coffee. I got them.
That's okay.
Do you have an extra? Yeah, I think.
Oh, I didn't get one here today. So we don't.
She's new. Absolutely.
Okay, let's get rolling here. Let's see what's next. So I'm gonna, let's see, can I do this easily? I want to go back here, way back. There. So we're still here in the environment. And we're going to begin to get into here the rest of the day. So we're going to get through the rest of this pretty fast. So you kind of know what's going to happen here. I hope this doesn't make your car sick.
I don't have to.
That's good. Okay. So this is the rest of the policy conversation. This is the state stuff that we're doing, and this is this legislative session. By the way, this legislative session is going to go really, really fast. It's a 60-day session, and it probably will be a 60-day session because they don't want to get out so they can go start getting re-elected. Which you notice the theme from Congress is a certain theme. And the good news about that is they're not going to be here till July, and I'm going to spring training on March 18th, so they will be out. But it also means that if you have stuff you want through, you better get moving because that means the initial cutoffs for bills to move to the next level is like next week. So we're moving through, and I'll tell you about a couple of other bills that SVHD is working on in a minute. So mental health increased funding. I mentioned earlier there's a bill in there that's going well to get some additional loan repayment money. There already was a fund. We're trying to add mental health professionals to it to help get more providers in the business by giving loan forgiveness. Pharmacy Commission, I don't need to go off on this except, I don't know if you guys have encountered this, I bet some of you have. The Pharmacy Commission have you guys encountered this? Oh, well, you know what I'm talking about. You know what I'm talking about. Well, I should let you do this part of the presentation.
Yes,
well,
there's a need there.
There was a Pharmacy Commission. There has been a Pharmacy Commission for a long time. And the laws related to pharmacy are out of date. And so the Pharmacy Commission and the people running it were pretty smart about recognizing that certain things didn't make sense and so on. So they through rule and so on, they handled it rather well, worked quite well. Things like allowing for rural hospitals that aren't open 24/7 to have access to pharmacists to drugs when they need them on the weekend and so on. Well, this new Pharmacy Commission came in, and no one can figure out exactly why, but they decided to start construing this incredibly narrowly, resulting in all kinds of problems. I'm not going to take our time with some other stuff to go through today, but and it's caused big problems. And the Pharmacy Commission resides in the org chart under the Department of Health, but the Department of Health, candidly, quietly at the side, is also stressed and embarrassed by all the stuff that's going on there. And we've been working with them to try to figure out what we can do. The working with the commission to try to help them understand TAC hasn't worked very well. So there's actually legislation that's forcing them to construe things the right way. And we're working on a number of pieces of legislation there. So it's been very bizarre. And then there's a bill by Representative Cody and Representatives Cody and Jenkins that would allow for someone who has to get a limited medical license for those who've completed medical school but not residency. I'm not involved with that, but the WSHA people that are ran that by our members and their CMOs, and they said, no way, almost as one. So, and so this is not something that, at this point I think we're neutral, but that's where that's at. And then non-competes, I don't know if you know about that, but this is really a much bigger deal, I think, in larger hospitals, but that's the idea where when you hire a doc, it doesn't just have to be a doc, but it usually is in these situations, and then you have the contract that if they leave under certain circumstances, or sometimes if at all, then they can't compete with you in the same market. Essentially, that's it. And there's a whole variety of the range of hospitals that don't even use non-competes to those that use them in a really narrow way is all across the spectrum. So WSHA tried over the interim and I think successfully, to try to get some middle ground of what made sense there. The problem is that there are certain places like you can see this from both sides actually. I mean, there's some places where big institutions spend a lot of money to bring specialists in, and the specialists come in and they're there, and the reason they spend the big money is they think they're going to amortize it over out the next 20 years or 10 years or something. And then what happens is the person moves across the street and starts their own practice, and we've lost investment and so on. That's the hospital side of the story. The other side of the story is, the doctor side of the story is, well, we came here, we did this, we paid back what we did in all the benefits we brought you, now we want to go and do our thing. Anyway, that's a mess that we're trying to work that out. That's enough for that right now, unless some of you have had to deal with it. I'm talking about it. I don't even know if it affects you guys. So, And then non-legislative policies, there's payment transformation. Now, this is all part of the Healthier Washington conversation, and most of you know, if you don't, that about like almost a year and a half ago now, the state got a $65 million CMI grant. That stands for Centers for Medicaid and Medicare Innovation Grant, to really redo the way Medicaid is provided. And the state's whole move to try to do a zillion things, which we're not going to get into in great detail, except it's to take they believe, as between Medicaid and Public Employee Benefits Board, and then potentially schools, the state already controls something in the 30% area of the healthcare market. And if they control 30% of the market, they believe they can not only affect that 30%, but they can leverage the rest of it. So that's exactly what their Healthier Washington thing is doing, and it's trying to move this out. The things that are most significant about it are a number of things to try to integrate mental health and later other services with medical care. That's an important point, because remember what you thought about your mental health issues and how you might think about that going forward. And to put some of the decision making down in what they're called accountable communities of health, of which there are 9 in the state, in local regions, so that at least some of the conversation about health becomes a local conversation, not just a hospital conversation or a state policy conversation. So.
I'd like to add a little bit to that. Jean and I were at a meeting where King County came out, and they have, in sales tax, there is monies for mental health. So King County has been going out to different parts of their district to find out what the mental health issues are. And I would say this community was well represented when King County came out. Wouldn't you say, Jean? We had a table much bigger than this, and it was full.
Excellent. Good.
And it's
So
for
they
that.
came to your alliance meeting? Is that where they came?
No, they were at Preston Community Club, Sapani Valley Community Network, I think was the entity they used to do it. So it was,
Yeah, Snoqualmie Valley Community Network.
did it, and there was schools were there, we were there, Jean and I, a couple other entities, but there is, the mental health stuff is starting to be available, I guess is what I'm saying, funds. And they're looking at how to spend them, so now's the time to ask.
Well, what we identified was a central point of contact is needed, because actually we have so many different agencies, people don't know where to go.
Right.
So a community resource center was the bottom line, I think, of our conference.
So that's another important, and how that might end up looking, and whether your role is supportive or leading or whatever, all questions for you to think about when you get down to tactics.
Yeah.
But thinking about that, there is that need there is really something to put on your list. And again, you may say that's not ours, but we have to make sure somebody else does that. But at least you know what the universe is important. It's not plastic surgery, if you know that.
Redmond does have that already, the Redmond Resource Community
Yes, they do.
Center.
That's right.
They have that already to bring in all the.
But
staff.
I still think that's my personal opinion, it's just my opinion, is that we're going to try to work the Chelan conference theme. My idea for the theme this coming year, I'm giving you an inside scoop here, but is that, is
That
it's
means we
good.
get to talk to you afterwards?
Exactly. And I'm not changing my mind, no. Is this concept of anchor institutions. It's a concept that is old in education, higher ed, and relatively 10 years or so old in big hospitals in big urban areas. But when I read about this, I thought, you know, it's really what rural hospitals need to start thinking of themselves as, is what are, as the convener of the healthcare conversation. Doesn't mean you do it all. And there's still, we're going to get to this conversation about core competencies, and that's what you have to put this up against. But who better? I mean, so I know you're right. Redmond does that. Redmond does that, but who knows to call Redmond? I mean, if I'm in Kirkwood, you know, or you know,
So, and remember, somebody contemplating suicide is not going to wait for office hours.
yeah, precisely.
And that's why the idea that Snoqualmie Valley Hospital might be that community resource center,
Yeah.
because it's open 24/7 in a way.
Or even if you didn't want to go down that road, but you had some space there and you helped facilitate it happening. That's, but you know, again, it has to tie back to your needs And it has to, but anyway, I'm spending too much time on it. But I will say this, one last thing on the slide, and then I think we're done with this stuff, is,
So, just by the way,
Oh, sorry.
Snoqualmie Valley Hospital does deal with that. I've referred 3 people to emergency, and they've been evaluated. So that's being done right now.
By social service,
Yeah.
social service function. And that's fine.
We do
but the
that
word-
right now.
But the word needs to get out because this group of 30 people, exactly 30 people, we're aware of this.
see, I think it's 2 different points. I think one is they're not aware that you are doing it, maybe, that's an important thing. Number 2, it may be a somewhat different point, that there may be, I mean, like the crisis clinic does some of that in Seattle, and they do it for King County. But how does that work with your population? Is it linked up? Do you know? I don't know the answer.
It's not, and I think we have to be assuming that we're gonna be the major
Yeah.
role
And,
player
Yeah,
for them.
And reaching out to the public, informing them, so.
exactly. And I'll tell you one last thing, and I did talk with Roger, and this has been 6 months ago, so this may well have changed, but, and I've worked all my whole life in health and social services in King County. And there is, no matter how much you say, whether it's South King County and the somewhat rural areas, or your area, King County doesn't get rural, typically in health, unless you raise it. And it isn't that they're mean or bad or anything like that. It's that they look at the numbers and 98% go like that direction, and they imply these kinds of things, and you do, and so they're really being incredibly responsive. Except that a lot of what you need is not going to be the stuff that pops to their mind, because you have a different set of systems here, different cultures. So I say that to say King County Public Health is the King County ACH leader now. And if you don't have somebody regularly participating in that, you ought to. Because, okay, good. That's
Better work.
all right. All right, internal assessment. External, internal, remember? Okay, what's your mission, vision, values? I'm not gonna embarrass anybody, but I wonder if you all know, if you could recite what your mission, vision, and core values are. You think you could? Okay.
And it's cheap. I studied it. Mission, to promote the health and well-being of people in our.
Oh, hey, you're reading it. That's cheating.
I can see she's not.
Well, I'm gonna tell you in a minute,
I
but
try my best.
But I think a good refresher, you've probably all seen this before, but a good refresher as we start thinking about internal is the mission shapes today. It's what we're doing today.
Not the best.
Our vision are never the best. There's no hospital system that's doing the best. And so if you're going to look at the glass being half empty, you will fail, period. So vision prepares us for tomorrow. And then we can prepare for tomorrow if we believe in our values. So those things fit together. So what's your mission?
There it is.
I don't know how this comes from, what the story behind it is, or how old it is, but I
Does
think
it need to be revised?
it's a question. I'm not saying that's a right or wrong answer, but it's always a question. And this is your vision. And these, oh, I see, these are your values. I'm kidding. So those are your values.
Steve can relate.
That's right.
Can
Right?
you go back one more?
Yeah.
Sure.
You know, you almost need to define what safeguard means.
Yeah.
What is safeguard? And how do you, in light of community health, and this is my thing about the Affordable Care Act all the way around, how you force people to be healthy.
Yeah, and also safeguard has the smack of status quo. We need to say promote and enhance, something like that.
So let me say, I think it's supporting both of those comments. Let me say, and there's no, you don't have to do this like run right out, but it's something to be processing in your brains. 2 things. Another one of my favorite Venisms is, where there is no future, there's only past. And what I mean by that is, if you yourself or your constituents, the people that pay the taxes and vote for you and so on, don't have a palpable sense of a future, they will devolve to the past. And that's human nature. That's not anything about you. It's not anything about them. It's if you can't see something out there that's compelling, that's dragging, that's, whoa, we can do that, then your natural default position is going to be. And this isn't to say that what you're doing is the status quo at any point. And that, by the way, this is exactly the same conversation I would have with any organization, not just any hospital, but any organization. So it's not, I'm not selecting you specifically here. But doesn't mean that what's happening currently is bad.
No.
If you're not thinking, though, about what that future is that you're going to enroll, when you often have issues in communities around healthcare, it's around people who get upset about things, either that had to be done by the board or by the executives because they were the right business decisions, or because they completely didn't understand anything about healthcare. Well, you can't, a lot of people talk about, we got to go out and educate the community. It's not about educating the community, because it's about making the community want to be interested in enough to become educated. So it's like you have a vision has to instill a compelling sense that people want to join you. They want to be part of the conversation.
This is where the action is.
Yeah, right.
Energy.
Right. So if I were doing anything with yours, I would think that in the future you might think about that. I don't think it's anything I can do right now, but and visions often they're just paper. We don't think much about them. That's also a problem. I mean, if you're going to have a vision, you should live it. You should, GE, progress is our most important product. How old am I that I know that was their statement? But I mean, but I mean, I think people really have to get into it. It really defines your brand. In fact, my last quote about that is what's that Gretzky, Wayne Gretzky, the hockey player, said, what's he say? What's the quote? That's right.
Yeah.
Did you know what he said?
I'm surprised he didn't say.
What did he know? I didn't quite heard it.
Skate to where the puck's going.
If I heard it.
Oh, yeah, go to where the puck is going to be.
Right.
It's going to be.
Right.
And that was actually a quote by his father.
Is that right?
Yes,
Really?
he took credit for it.
Okay.
It was an interview last week.
I take credit for it all the time.
That's exactly what we're trying to do to meet the changes in healthcare coming down the pipe.
Correct, because if you're trying to now see, that's the tough part in a changing system, is you don't get to forget about what you do in the day and go out and do this stuff, because then you go broke, because you're not maintaining things. So this is the tough part, and why you all have to be focused and rowing together is you've got to be knowing that, but also knowing that you're going to have to get here. So the minute you start saying, well, we're going to drop that and we're going to go here, I've given you 3 examples today, and I probably think of 10 others, where the ideal is ideal and you'll go broke. Until the payment systems are in place, so your infrastructure is in place. We talked about some of the folks in the ACOs doing it so that they can learn about getting the data and learning how to operate. That's all about that. That's all about getting to where the puck is going to be. So that's all of that. Enough of that. And we did that. I think those are pretty good values. I mean, it's hard to beat those. If they really are our values, that's the question. So, hospital capacity. This is going to get into some stuff. And what I want to do with these next few things is I want to get started on some processes that I hope you will take forward. And this is where I said I don't have enough time to do it all today, but I think if I've succeeded, it will have gotten you hooked, so to speak, in the process. So you kind of have to take the next steps of processing these things going forward. And I was thinking, we talked, this whole thing was internal, right? Well, there's a lot of internal that's not in this room, or only partly in this room. And that's the whole rest of the culture of the hospital and so on. So this is something that the administration is going to have to think about, and you'll have to think about. But maybe you want to take some of these things forward and begin to start looking at some of this stuff, and then coming back and filling in some of the stuff I'm about to get into with you later. But I wanted to be sure here that we are going to get into it, but we're not going to try to solve it today. So this is where I'm going to go next. This is the SWOT. And you've all heard of the SWOT, but I don't know if you always looked at it quite this way. At least I haven't. hadn't until I saw it done this way. So obviously strengths, what do you do well? What unique resources can you draw on? What do others see as your strengths? And by the way, I really loved how Dario opened this in terms of what you could say about other people. But at times when we're, and it isn't even that we're all being quote unquote too critical, sometimes when we're all heavy into problem solving, my wife has this great saying that I finally learned, we've been married 31 years, I'm a slow learner, is that she said, because I always want to say, I gotta tell it like it is. I'm gonna, you know, this is the truth. I'm telling because it's the truth. And she said, you're right, it is the truth, but is it helpful? So, so I shut up occasionally. But anyway, so when you think about this in terms of the strengths, in terms of what you have that you could capitalize on moving forward. And we'll talk more about that when we talk about core competencies, which I think is another way of saying strengths, actually. Then what are your weaknesses? Now, strengths and weaknesses are the internal game. Opportunities and threats are the outside game. And a distinction I make too here is sometimes when I'm thinking about this, and I've heard a little bit of this today, a distinction between the word possibility and the word opportunity. So what I do is, and I think both kinds of conversations are really important, but you need to think about what the possibilities are first, and then you need to think, given our resources, given our core competencies, given what we can make happen, what are the opportunities? And some of those are immediate, and some of them are short and mid-term. Probably, we get past mid-term, they're probably not opportunities because you can't know enough about stuff any further out. But so one of the problems in having this discussion is people get all mixed up in possibilities versus opportunities. You know, one day we could be, you know, yeah, you could probably, you know, take over Swedish, maybe. But what's the opportunity there? And so it makes you have to ground your assumptions. You can't just go off, right? So, and then threats. And this is an important one. This third one, it's really the one that is not the most obvious to me. It says, what threats do your weaknesses expose you to? So, again, another thing that is hard for most of us to learn, but probably most of us have learned right now, is just as though, although we would rather not hear about bad things about ourselves, if there are issues, we'd rather hear them than have them people judge us but not hear them, right? That's true of organizations too. So this is not self-flagellation. This is looking at weaknesses in the sense of opportunities to improve. And so it can't be, if this is going to be helpful to you, it can't be, let's just beat the hell out of ourselves. In fact, that would be a waste of time, and worse than a waste of time. It would be undercut your whole purpose. But if you look at them from the perspective of what are the weaknesses and and what are the threats that those weaknesses create, then it brings you back over here. Because if you can see what the threats are that these cause, then you can begin to think about what the opportunities are to address them. So this is real work. So what I'm going to do, and I'm not expecting this is going to be the end point, but what I'm going to do, and I talked to Tom, I didn't talk to Roger about this, so you can veto this, but is I'm going to have these around and let you spend a little time working on them, and then we can talk about them a little bit. But then that's all we're going to do with this today. Then you guys are going to take it back and maybe run it through staff, decide what you want to do, but do the same thing, and then distill it down and process it later, but not try to do all that today. Does that work? I know you'd rather have it all done today, but
Well,
I can't stay till
we might be able to touch on it briefly.
Oh yeah, we can process a little. Yeah, sure. But I'm going to tell you, there's no way in heck that you can complete the conversation.
What I said to Ben is I also want to get perspective from our management.
Right.
From the managers who are working, and they see things that we don't always see. And I think it would be really helpful.
Sure, it's data.
Gather more.
It's also interesting too, because what do the commissioners see and what do the staff see?
Right.
And are we on the same pages or are we on
Right.
different pages?
Exactly, and again, it's data. If you aren't, if in a given area you're not on the same page, that's an opportunity to figure out what people are seeing or not. If you are on the same page, that's a potential, that could be a great thing, because it means you go forward. It also could mean it's a blind spot, because you both have it, so. So I'm gonna give you just maybe 10 or 15 minutes on this right now, because I don't want to spend all our time waiting today, but I do want you to spend some head time, so I'll shut up.
Would you have one to do some of the staff back there, just so that they see it
What we're talking
even
about.
better? Is that all right with the rest of the staff? Okay, we're here, might as well get them.
I'm a public member.
Yeah, but.
I'm
Yeah,
in
sure.
public kindergarten.
You can see too, I don't care. They don't care.
And also, these folks could pick up some of your handouts, could.
Sure.
Uh,
They're public record.
Exactly.
There you go. So maybe if you're still only in the top box or the top two, you might want to try to just not try to write the great American novel in that box and go down to the other couple of, so we're going to stop this in about 3 or 4 minutes. Okay, let's wrap it up. Oh, there's no right way. It'll be fine. It's more what goes on in your head than what goes on down the paper. So, but if you didn't write it on the paper, it wouldn't go through your head. Okay, so who wants to start talking about some strengths? And what I think we'll do here, and listen, if this is okay with you, is I'll just kind of move us along to get some flavor for things, then move us along, knowing that we're not going to resolve a question, and some of these things are going to necessarily generate, well, that could be a strength and that could be a weakness, because it is. You're going to come up with it. So we're going to be comfortable with a little ambivalence here. So, okay, with that in mind, strengths. Who wants to start?
I think on the strength, what I see now is that the meetings are open to the public. The public's involvement is there, and it's a given.
So I'm going to ask you a question. I think that's a great strength, but I have to ask you a question. I'm intrigued by why, after all of this stuff we've talked about today, not that that would be on the list, but that would be the first thing you would say. I'm just curious why, because not that that's unimportant, because it is important. But
what I said in the past, not too many people. It's not very effective. A way of reaching out to people when you don't provide that opportunity for the public to
be engaged, to not
be
be
engaged
engaged.
in the community. Yes.
That's great. I've done a lot of thinking about that very topic, and I don't want to derail us now, but I'll come back to it because that's a great topic.
Yeah, thank you.
Okay, other strengths.
Are
There we
we
go.
doing strengths?
Yeah, just strengths.
I think one of the most obvious is a new facility. We have a brand new facility that's nice, it's clean, has some updated stuff, so that's
Great.
that's a strength.
And who else? Dave?
Well, we have a great line staff and management staff, I believe. You know, every time I go to a function, everybody seems to be very happy to get along. We're very happy to be together. And that's a sign that, you know, people are happy with what they're doing for the most part. And when 150 people come to a Christmas party out of 175,
Exactly.
something like a high percentage for a long time.
Yeah.
Just to hear Jay sing.
You know, there's some reason to that.
Yeah.
When you don't have malpractice actions going on, when you don't have major complaints about, you know, to a board member, that's kind of golden.
Yeah.
And so that's a strength.
Yeah, you're right. Good point. Gene?
Yeah, I have the proximity, and we're selling that by stay local. The critical access hospital reimbursement is definitely a strength, and our caregiving staff.
Great. It's really good.
Well, I'm goes along with this administrative team with a vision for the future with integrity, available paid care, and open-minded.
Great. Kim, you have raised your hand one time. Let the staff jump in here too.
We really live our values. So our values truly reflect who we are. And that collaboration and innovation are beautiful.
Great. Yeah, I thought that when I saw your values, I thought that same thing. That was a good point.
Bootstrapping. And what I mean by that is we have a history of overcoming barriers.
Steve.
Actually, all of mine have been hit.
You're not very original, are you, Steve?
No, I'm really not.
But you know, you got that.
Yeah, I know, exactly. Roger, you're the one who's saving the best for last year.
Well, I long time, I've worked flexible and certainly patient-centered culture, caring staff, and I think we have really effective and efficient processes.
Really effective what?
And efficient processes.
So,
I'm used to saying, speaking Rogers, we all know Rogers on loud talkers.
I want to add one that I didn't say, which nobody has said, and that's that we're rural.
Rural?
Yeah, as much as it can be a weakness, it can also be a strength because of our community being healthy and people come out here because we are rural.
Yeah, that's right. I do think you have a very interesting and unique situation. Hard, as I said initially, because it's not like any cookie cutter, but also lots of opportunities because of it.
Yeah, you know, technically, we're a rural hub,
Right.
but we're really part of the metropolitan area.
I know.
And the idea that you can go from our new hospital site to this rich resource of some of the best hospitals in the country
Right.
within 35 minutes.
Right. And also beat us in the Snoqualmie Pass pretty quick.
So are we rural or are we metropolitan?
And the answer is yes. It's like the when you get to the Yogi Berra line, when you get to the fork in the road, take it. So anyway, so all right. So let's go across the top. What are our weaknesses?
Rural is also our weakness. As much as it's a strength, I had it in both.
I can see that. By the way, this is a good chance if any of you want to sort of say right on or I don't understand that or whatever. So don't let me.
I think you're right. We're small in a big market community.
Oh, this is weakness.
We have
huh?
Swedish,
Yeah,
we have
Swedish.
Evergreen.
Okay.
we
And I
have-
put those down as threats, yes.
And so, you know, that's,
I think you both with strength.
glass is half full or the glass is half empty.
Right.
I'd also say that a weakness, I think, in attracting the median age of 36 years old is district to use services is we really don't have that continuum of care from baby to death. We don't have it.
Right.
And that's how you attract people and keep them in your system.
Right.
And so maybe it's because we're too small, we don't have that. Maybe we don't have enough collaboration. Maybe we need to affiliate. I don't know. There's opportunities behind that. I'm
Right.
not saying that
No,
it
right.
can't be correct.
No, I think that's a rich area for discussion. I've got a couple slides that I think will help with that, but it's not resolved. I don't think my opinion is, based on most rules, you're not gonna probably have the resources in this market to be everything to everybody. But the question maybe isn't how do we become everything to everybody, but how do we be part of and even an integral part of a system that collectively provides everything to everybody or what they need. So that's what I would suggest. That's one of the back to the strengths. That's one of the strength sides of that rural-urban connection you have. But more on that later. Other strengths, John. I'm sorry.
I think the biggest weakness as someone who comes from a lower part of the valley is the lack of understanding of what a district is and what services are and how they can get to them.
The lack of understanding among the citizens,
Among the
residents. Right.
I
Great.
could also say the lack of cooperation between administration and commissioners.
Mhm. That's a completely separate weakness. Yes. Okay.
I think weakness, I would say cohesion.
Cohesion?
Cohesion, I think we need to be more cohesive and spend, not only in our personal life, but professional life, so that we can achieve the goal that we want to achieve.
So I like that word a lot, but I want to be clear, we're on the same page. So you mean cohesion among all the players, whether that's the board or the staff?
Internally, top down
Yes.
management.
Right.
As well, yes.
That's right. Sometimes when I do this piece, I use a slide that I found of these guys, this lovely image of people who are rowing teams, but they have to have every oar in the water at the same.
Yeah.
And then I have a picture of one where they're not rowing. Which is pretty-
Different directions.
Yeah, so no, that's right. But I would just say one last thing about that. That comes back to that point about vision. If you have a common vision, that's how you get cohesion. All right, so other weaknesses.
Well, talking on the financial side, and not talking about the past, we're talking about today. 70% is no pay, 99% or something less, as in Medicaid. So 70% of people that come to our hospital for services is
Aren't
less
paying
than
full cost.
paying full what our costs are.
That's probably right.
And so, I know it's right, because I look at
That makes sense to me.
And there's 30%, again, that provides opportunities on the other 30%. But that's, looking at that, we have to turn that into a positive.
There's a number of things that derive from that fact. And turning that into a positive generally is the right goal, of course, but that does also relate to some of the changes in policy that are happening. I'm going to suggest to you as something to not only think about, but consider influencing and positioning yourselves for, is the fact that I don't think that cost-based reimbursement for critical access is going away per se. That's the wrong target. I think what is more likely to happen is that it will become available. I'm talking about both Medicaid and Medicare here. That it will become available to do different kinds of things than what it is now. Right now, cost-based reimbursement for Medicare, the conditions of participation are such that you cannot do anything but an acute care hospital, which is dumb in a lot of areas, especially when you've got some right around. You can't do it. But there are actually people listening at state and federal level, including some people who are asking us to help with pilot projects, to help think through what those cost-based dollars should go to support. So it isn't as simple as, yes, cost-based critical access or not. It's how can we influence how those dollars get used in the future. And again, that's not going to happen on Tuesday, but it is also not something that nobody's talking about. It's actually a viable discussion. A significant portion of one of my colleagues' time, Jacqueline, at WISHA, is spent on that.
Are you saying that based on potential for future adjustments, and that an actual facility change for cost-based reimbursement would be a cheaper fix to be able to care for these people?
I don't know what you mean exactly.
We have people that our swing beds they could be in there from 3 to 365 days, and are you saying that there could be a different type of facility?
Sure, I'm saying another thing. I'm saying
With
with regard to
all
elderly
the
people, like I said.
Bells and whistles of a hospital.
Sure. So for example, taking one population, those older people that might tend to use this, the whole older American elder care, long-term social service, whatever you want to call that support service system is terrible right now. Nobody's making any money. People are going bankrupt. And the rate change legislation that's going to come out of committee tomorrow in the legislature makes it worse for rural SNFs because it's more acuity based and they can't live if they have to do that. So that's the terrible part. The upside part is that there are beginning to be conversations with this global waiver, for example, that the state is likely to get from the feds, where they can take the whole continuum of care for long-term care for older people, and not have to spend the money the same way. So they can afford to pay more for home health, right? Because even so, they would save money over here on the other side. You can't do that now because it's required that you spend the money that way. That's an example in that population. I think for other populations, there are examples that say, if we've got somebody that we can manage, we can help them stay healthy in their community, and we can manage the chronic illnesses afterwards or ongoing. We don't need as much people in a facility, and a facility then becomes used for different things, or it's used for more acute people. That's going to save money. But right now you can't do that because nobody pays you to do chronic care management, and nobody pays you to do prevention, other than a little bit. But there's a little bit now. But Medicare's got a thing that I don't think I use this, but relatively few people do. There's something in Medicare where you can actually get reimbursed for doing but not much of it's done. Much of it's paid for. Sorry.
I think one of the weaknesses is we like to hear compliments about our hospital, but we don't like to hear criticism. And you know, when I go on Amazon to buy something, I'll read one or two of the 5-star messages. But I go down to that's the 5-star. But I go down to the 1 or 2-star to find out what is really going on and what problems might be with that purchase.
Yeah,
I'd like to hear, well, for example, the Snow Valley Star did an article that said, major decisions are made at the hospital with little public input. And that was some time ago by the editor. But
how did the first thing you said relate
I
to
don't
the
think
last
we're
thing?
getting the true picture, because I hear people stop me on the street and say, I'm not going to that hospital because. We never hear that as a group.
Well, I do. I hear, I ask people, a lot of people don't know I'm a commissioner. I ask people
Why they don't go come to our
Yes,
hospital.
I do that. And I hear it. So I hear it. I hear it. And
But we don't discuss it as a group, as a problem, as problems we need to solve.
it's come up. It's come up over and over and over and over.
Coordinate
I mean,
is
it's not that we're not trying. It's not that we're not committed. It's not that we don't have great staff. It's not a lot of things. What it is how we're set up in the type of situation we are at, and how people use the facilities or cannot use the facilities. And that's what it is. So
whenever you get a bad experience, which can happen anywhere, whether somebody makes a mistake or somebody just has a personality difference, something happens, they can't see you quite as quick as you think you need to be seen. Those things, people don't forget them.
No, they
they
don't.
tend to hang on to those. So then they're negative when really nothing that major and negative happened. It just said, well, they didn't take care of me the way I wanted to, and so I'm going elsewhere.
So 2 thoughts to throw in. I think those are great comments. One is, it's one thing to think about, because I agree with you. I think it's certainly in my life, again, I'm being an only child, and I have siblings to tell me what I should be doing, so I assumed I could do anything. But so I think getting
So you got
feedback.
married.
Exactly. But getting feedback is necessary. Finding what you can do better. But there's a great saying written by someone I read back in the 70s or 80s. That everyone tends to think, I used to be wrong and now I'm right, or this is bad and this will be great. And it's much more effective to say, I used to be right and now I'm a little more right. And that's not just a turn of a phrase. It really changes your attitude toward how you think about where you are. If you're and then the third thing I was going to say is the thing I said before, where there's no future, there's only past. So if you come to a situation where you hear problems, and what you do with that as commissioners is grumble or just raise it because you need to raise it, I would suggest to you that if you stop there, you're being irresponsible. But it's not to say you shouldn't say it. It's to say what you should do is say this, and then let's talk about whether there are similar things that people get, and if there's not, move on. If there are, then what are the causes? What are the things? Are they things within our control? And so this is an adult conversation. That's what you do as adults. And so I mean, I think the issue here is not, should we only be happy talk, or should we only be, negative? You should be all that. You should take a lot of pride in the cool stuff you've done, in this building that you've done, and the stuff that you guys do every day. And does that mean you're perfect and should never change? Of course not. You'll die if you think you're perfect and never change. So you've got to be, all of you, individually, got to get rid of some of that black and white either or stuff and get in that both and place. And then you'll start working together, and then you'll start moving further ahead.
I think
And
also
that includes more feedback from the public.
Yes, if properly handled, but feedback from the public, just because it's feedback from the public, which is often engineered anyway, isn't the only input you get. I'll give you an interesting statistic, and this is for the folks from the public who may be here. The public hospital district statute does not require that you even take public comment at board meeting. It doesn't require that you even take public comment. Is that because they don't believe it? That's a fact. I know the statute. Does that mean that you shouldn't? Of course. Let me finish my sentence because you'll see where I'm going. Does that mean you shouldn't? Of course not. Of course you should take public comment. But it is that way, not because they forgot to put it in, but because that's not the primary reason for a board meeting. The primary reason for a board meeting is for you to do the millions of dollars worth of business you're doing on the community's behalf. And if you're spending all your time being open for input during a board meeting, you're not doing that other stuff. And I would argue, derelict of duty if you're doing that. Now, does that mean you shouldn't have opportunities for input? Of course you should. It just may not be your board meeting. Maybe you find a topic and you go out and you actually get community input that's facilitated in a way that actually makes some sense. It isn't just somebody throwing rocks or happy talk or negative talk for the sake of it. If you really believe in community engagement, then do it in a way that you can get community engagement. Don't, headlines in newspapers, I'm sorry, headlines in newspapers are not something you could take.
They affect people whether they come to our hospital or not.
Well, I know, but I'm saying it's up to you. If you're serious about engagement and you're not just using it as something to tip people up on the side, then you need to develop engagement.
I totally agree, and I think it hinders business that has to be done. And it really, really upsets me when I have to go through tons of time to go through irrelevant information. No, let me finish. At board meetings, I'm really upset when I have to listen to outrageous something that's not even the topic of the question for hours and hours and hours. And it takes away from my family and my business duty as a commissioner to do the right thing. No, let me finish one last thought. I represent attorneys that think, all the time on different things, and they don't practice my area of the law, and they think they know what to do on their case. It's like telling a family physician to operate on your brain. It's kind of ridiculous when people are telling you things they have no business and no idea what they're doing. They have no information and no knowledge and not enough background to tell me what should be done. And I think it really, I'm telling you right now, I'm venting right now because it's going to stop at these board meetings. I am not going to take this kind of stuff, going off and ranting and raging and picking fun of people and board members and going ahead and picking apart staff. It's not going to happen.
So let me just take some of the, I'll give you a chance too, because I know you deserve a chance, but let me just say, lest this go in a certain place, which it easily could, I'm going to suggest to you that this is not an either-or conversation. My degree is in community organization development. I have done more things, we can talk sometime about the stuff that I've helped create as a result of engaging communities in the process, including a lot of building the ACH in North Central Washington overseas. So I think community engagement is essential. But you ethically, you can't, but community engagement is not the same as letting everybody rant. But it does imply that if you mean real community engagement, that is a chance for people to really talk about the issues that are important and with some informed background so that it isn't just pooled ignorance, so it's useful both to you and to them, then you build structures that allow that to happen. But you don't assume that just because Joe says the sky is orange, it's useful information. That's disingenuous. So,
Yeah, what I'm observing here is that when you say board meetings, it should be structurally done. Board meetings should, to me, my understanding for me, is board commissioners should have a meeting. But what's happening here, it's not really a board meeting, it's more of a, everyone's input. So board should have, this is what I see, there is no work session for board to discuss more pressing issues.
that's what, by statute, that's what a board meeting is intended to do.
But that's not what I observe,
I know.
okay? And so this is where I'm somewhat disillusioned because I don't think this is happening. I run boards and we have board meetings and then we have meetings with the members. And that's two separate entities.
I just think you should.
You follow what I'm saying?
I do.
Yes.
I think too, there's different kinds of boards.
Mhm.
There are boards that are community boards, there are boards like Snoqualmie Valley Community Network, there are boards, every organization has boards. This board is a board that does governmental business. This is a board
I understand.
with tax dollars.
Sure.
So it has to run a little bit different than going to a Cub Scout board meeting.
I didn't hear a disagreement with that.
Yeah,
Maybe I-
so that's gonna be, so I think that sometimes we want it to be both, and it's not, it's one or the other.
I think that's kind of my point. I think we make this assumption, and you're not alone, lots of people in public hospitals who do this, make this assumption, and it's terrible for chairs, because chairs often have to be in the situation, as you guys will attest, have to be in situations where, on the one hand, I'm supposed to be making sure we make the decisions that are gonna keep the hospital open and viable business decisions. On the other hand, I wanna be open to the community. All I'm saying is, and it's not a value judgment about anybody's point of view, I'm just making a factual statement that those are different kinds of structures, different kinds of, so.
I'll just give a concrete example. A citizen told me that there's a real problem in the fact that the hospital does not have the scope of services that one would normally expect of an acute care hospital. As a result, we do a lot of transfer. All right, well, if the A card that brings you to Snoqualmie Valley Hospital, that's reimbursed, no problem.
Right.
But the problem is transfer payments with the second transfer, and now insurance companies are not wanting to pay that. And this citizen said that can amount to $1,000 on that second transfer, and that's why people want to go to Swedish or Overlake rather than come to your hospital, because at your hospital, we incur those extra transfer.
Yeah, and those anecdotes are important and valuable, but let's not make too many decisions just based on some anecdotes. Let's think about it. Yeah, exactly. So,
But back to here,
yeah,
what
that's where I'm going
what
to.
I'm hearing is scope of services.
Yeah.
Constitutes one of the weaknesses that we.
There you go. Nicely said. Nice transition. Thank you. So so there's a question there around what's the scope? Can we be all things? How, if we can't, then how do we link it up? Yeah, that's a great point.
Yeah, and I'll
Thanks for bringing us back.
I'll throw in one of my weaknesses is related to that, and that is diversity, not just the scope, but the diversification
Of service.
of service. So we are
Swing bed.
highly dependent on the swing bed business. We've been phenomenally successful.
Right.
So that's wonderful. I mean, it's all
Right. Okay, go ahead, and then I'm gonna move us on.
And I probably said it in terms of strengths and weaknesses. One of the biggest weaknesses we have, once again, I live in the lower valley, I talk daily to people and talk about the hospital usually comes up in it, and I talk about what we can offer and what. But there must be some inherent weakness in our ability to get that information out to people that work, I guess, in clinic in Fall City and things, maybe there's a little bit more. But people don't know what we are.
Right, well, or they find out that we have clinics and we have swing bed care, and we have some ancillary service related to the swing bed. But we don't have anything in between, so they're not gonna choose us. And that's what I've been hearing from just about everybody that I talk to.
What I'm hearing also is that how do you sustain a relationship with your community and the people. So best practice, even though you mentioned that public meetings, that I think best practices would be that,
Absolutely.
sustainability and viability.
I agree with you.
How we become very viable in the
And one of
community's
the-
perception.
And I'll end this by saying, one of the things that you gotta get to is, you know, like my CEO at Wisha, Scott Bond, actually stole it from AHA, I found out, so I stopped giving him credit for it, but said, what's the blue H on the highway mean? By the way, it's a white H, I pointed out to him. I can say that, I'm over 65, right, exactly.
And you know,
But, yeah, go ahead, Jim.
I was just gonna say, you know, what we're talking about too are threats. To me,
Right.
Swedish and Overlake and Evergreen are a threat as much as, I mean, because for us, they will take the patients that we might be able to service. So, and I don't know how you deal with that because they do offer the right.
So let's talk about threats, and let's talk about that as one.
Swedish Overlake, I guess you could call them threats, but the threats I see are more like Ready Clinic in the drugstores. Our lives are going faster and faster, convenience is the thing, and people work off the hill, they go by the Ready Clinic, that's where they're gonna stop. They're not gonna come out here. Back home, even if it's back home, that's more convenient for their lifestyle.
In terms of a macro trend, a lot of people talk about that retailing stuff, but I'd be interested, I would suggest to you that as you look at those, and that's why I think the processing part that Tom talked about is going to get to, is how many of these things make good sense sort of anecdotally, but what's the grounding? And what do we know about that? Because I think you want to try, you're not going to get hard data down there. It's just one
Not for
thing.
a while.
But you can begin to check around and do a little bit more check. So, because I think those kind of comments are really good, because they give you a hint of what some issues are, but then you have to go ground them and figure out, is this as big as a red box or as big as a red truck?
And group health is involved, and what you call it, multi-care.
Right.
That's a feeder system
That's
for
true.
group health.
That's right. That's how they've responded to that issue, that's right. Go ahead.
Median age, what is the
Right.
median age who we serve? I
You
would
said
like to know
36.
that, compare that to the median age in the valley. If we aren't close to that, we're not serving everybody.
Mixed
Well,
populations, very
No,
mixed.
but there may be greater need at a
There might be,
age
but
level.
I'm just telling you that if our median age we're serving is 50 years old, and the median age in the valley here is 36,
Yeah.
we're losing
Well,
all of
So we
those
looked at this
potential
distance.
people.
you've got several things going on at once there, and it's like, you can't, you've got that, but you've also got, what do you get paid for? Because some of those services you can't, or you can get paid for it, but you have to get 6 of these kind of docs that cost you $1 zillion to even offer that service. So there are financial issues to do that. So the conversation maybe, and I'll get to this in a second, but maybe less about, do we need to do all that? Or do we need to be part of making sure that's available to everybody, and this is our part of it?
Yeah.
So that's,
Well, then
it's
you go
what's
back
the
to
it?
who we are actually serving. Are we serving people outside of our district in the swim bed care?
Yes,
I would
we
suspect
are.
Yes,
we
we
are.
are. We're
So-
actually doing bed
So
planning.
how many people in the valley are actually using the services who pay taxes?
And what is it that you, using your knowledge, your core competencies, have to offer them, and that's exactly what you need to talk about. So, opportunities, I want us to do this, because I think this is where you really want to spend your time, but then I want to move on. So opportunities,
Young families,
that gets to your point.
that's what I put down.
Yeah,
That was exactly right here.
That they
There's
put-
an opportunity there.
I went from young families to the future, because that's where the future for the hospital district is. And 2, they don't carry the burdens of the old history that a lot of the rest of us do.
Correct.
That have been in the valley 40 years. So
That's great.
they go together. And if you want to live in a house, you're not going to do that in Seattle much longer. That dense population, dense housing. If you want a home, you're going to have to go out to the rural communities, and that would be us.
And we have one of the best school systems right here in the valley. Blue Ribbon, all 3, middle school, elementary, and high school. Now, there's,
So does the lower valley have good schools? I'm sorry.
Point is, they're not Seattle's, I think is maybe.
Yeah, they're not.
That was my point.
They're not
I'm just saying that people want to come out here for the school meeting.
We've already mentioned it several times, but as an opportunity, that's more services to seniors as we get an aging population. And then, I think there's an opportunity we're missing in developing a relationship with the Snoqualmie tribe for financial and caregiving purposes.
Although they actually have some other federal reasons for why their health care is different, but we're not gonna go down that road, because it's a big road. But yes, no, there's certain a lot of help written broadly that applies to, yes, absolutely. Other opportunities.
I know we are critical access hospital, maybe there's a possibility, hopefully, that we could have an OR or a maternal child health care service. But
Birthday.
of course, the threat would be financial burden.
Something that produces revenue.
Well, let me
Yeah,
tell you,
it
there's no
could be
OB program in the state that produces revenue.
Yeah.
OB is a lost leader. OB is one of the first things that would go if hospitals didn't have to be full service.
But OR is.
Some ORs,
Yes.
depends on
I
what
know
they,
because other organizations taking up on
depends on what they do.
in the hospital.
But yes, those are good opportunities. Anybody else, and I'm gonna move on.
I just got one simple,
Opportunity?
more opportunities, think outside the box of hospital. There are different kinds of clinic teaching things. We had an Compass in our outpatient area.
So-
That was there, and that's children.
So Joan, your opportunity is what there? I'm just trying to understand.
Opportunity are, think outside the box, to the medical services to be offered to other people
Okay.
than who we serve in the
So the
hospital.
opportunity is to take resources we're using now and apply them in other ways.
Out to the whole district,
Well,
like we did up at the pass.
John, I had also that, consolidating community resources, getting out in the community, pulling other nonprofits in, very, very similar to what you're talking about. And which leads us into the whole population health, is our ability to impact, wellness and population going forward, because that's where, if we're gonna shoot for the puck, where the puck's going to be, that's.
Plus, it's all really relates to that younger population too, as well as we have.
And also mental health, because now there's some funding for mental health. And I know we did that before, and I know we didn't, at some point it left when they had some mental health in this hospital.
Oh, did you try?
Yeah,
So I didn't try that.
So,
Well,
but there's funding there for that service, so that's an
well,
opportunity.
then we heard, well, we don't wanna go up there, because that's where all the crazy people are.
Some people think it's in this room.
I'm just not gonna say that, you can't get into mental health, maybe I didn't just say that. Okay, so, this is to both to what we just did and then to take us forward. This is that thing I shared with you about the mission values, creating resources. But this is their mission value, vision values we talked about. You can think a little bit more about your vision, get crisper about that. Then what drives the resource engine? So we talked about that. And then what are your core competencies? And the sweet spot is where they intersect. And we haven't talked very much about core competencies. And that's another exercise that we might not get time to do much about, but I'm going to hand out a brief article that I suggest you read, because I think this is huge. People almost never do this in any organization. They just get nifty ideas, and the funding says you should go there and you can pick up $1.50, and they go there. And that's why you see nonprofits that don't get mission creep, because they go after every grant that comes along, and that's a disaster. That's a disaster waiting to happen. I'm not going to get into this, but I would really encourage you all to spend time on this for a harmonized combination of multiple resources and skills that distinguishes a firm in the marketplace. Now, you've got to kind of play with some of these words, being a public hospital district, firm and marketplace is not quite the same, but you get the concept. And this is what I like. Core competencies fulfill 3 criteria. It provides potential access to a wide variety of markets. And your point about Jones said about thinking outside the box and using some of your resources differently in other ways. So what do you have this core competency, you do this really well, maybe because you're swing bends, everybody, that's one of your big things. What are the things that you have to do well to do swing bends? And then, are there things we could do with that we're working from our strength that we could do some other things with? It should make a significant contribution to the perceived customer benefits of the end product. And in other words, what your core competencies are going to create a product that's actually better for the beneficiary. And it's difficult to imitate by competitors. Now, oops. I love this as an example. For example, a company's core competencies may include precision mechanics, fine optics, and microelectronics. This helps it build cameras, but may also be useful in making other products that require these competencies. So, very important piece of don't gloss over it quickly, really lean into it, conversation is what are our core competencies? And maybe, but don't get these all confused, what should be our core competencies going forward? So if we see that the future looks like this, and these are our core competencies, how does that fit? What are you going to need to get there?
I think it also says, don't choose a direction that you're not just competency to even start.
Unless you have a plan to get there. Yes, I agree. I mean, that's right. I mean, I think, or another way maybe to say that is, you got to start with what you have. And if you realize, it's like the old journey, you know where you're going, and then you kind of map backwards. You still got to start where you are. So you may realize to do that, we're going to have to change this, and then that's going to lead to changing that. But at the end of the day, you can't just start doing brain surgery because, geez, that would give us a lot of money. So this is really the significant part of this. This is where it all leads, and this is where what I thought I would do in this, because again, I don't actually think it's even my job at this point to really talk about what that is. I think it's you to go through those steps, and then you'll get here. But I did want to open up your thinking a little bit, because I think, and I suspect you think this too, but I think you've got a very rich future. I think if you really begin to think about the things that make you struggle or frustrating, or the limitations that you have, you really do have a lot going for you. Go back when you do the analysis and dig down into your SWOT stuff. Go into those strengths. Go into what your strengths are that you really know. And I bet you just scratch the surface. I bet there's a lot more of them. And then start building on those. And then, but these are our strengths. This is where the world is. So what's that? How do we put that together? I'm not gonna. I can't tell you what that should look like. I will use this. And how many of you? Does anybody here not know what that is? Okay, but so you all know what that is, right? That's AAA. But the thing that no one talks about, and this because it's harder to talk about this. Like before, we were talking about community engagement. And I said it's not this or this, it's both, and you got to do they're different. This is the tougher thinking. This is where your gray matter really is important. This is not about it. So I always tell the story. One time I was in a car, to get my car in to get fixed. And there's a sign on the wall that said, "On time, quality service, low cost. Pick two." And very often when you think of the AAA, people talk about the AAA, but they talk about it because they're in a clinical environment and what they really mean is this. Yeah. Or they talk about it because they're in Steve's job and they really mean this. Or they talk, and sometimes they say, okay, well, look, we can have better care at lower cost because we can do this and do that. Where it gets tough is doing all three. That's the challenge. And even though, what's his name? The guy that thought of that. Brewer, right. It's true. I don't think, and I think he got it. It's an elegant statement. It really is the answer. But it only is if you think about all three together. It's how do you make it work? Because frankly, anybody can do 2 out of 3. Yeah. And if you do 2 out of 3, you're going to die.
that's the prospective DRG payment system.
Exactly, that's right,
We've been excelling at that since the mid-eighties.
right, that's right.
Wouldn't you say, Tom? I couldn't hear you.
Well, I'm sorry, but, we don't get paid this way, but other acute care hospitals get paid on a DRG basis.
Yeah.
And they spent the last 30 years perfecting, providing really good care for patients for as cheaply as they possibly can, because they're gonna get paid a set amount for that acute care encounter.
And they've done nothing about that.
And nothing about that.
And you're a community, that's where this district thing is significant in this conversation. Because Roger just said it, this is where the world is going, and that's one of your core strengths and one of your core competencies that frankly other people don't have.
That's in our mission and values.
It is, and other of your competitors don't have that.
I have to make,
Sure.
Roger asked if I would attend the Accountable Communities of Health
Right.
meeting. One of the most troubling things about that group, and,
Is this King County or the big?
No, that's,
No, I mean, it's the King County Common Community.
the King County one.
I just want to be clear.
Led by King County. And that is the fact that the lack of representation in that room, by the people that I think really are so, there are people in that room that definitely have at their core, personally, they want to do what's in the purple triangle. But the problem is there aren't enough people in that room that have been working on the right two triangle, the right and bottom triangles, who are able to actually make a difference there. So in my mind, I fear that we're still in lip service mode. That room has a representative of every hospital or system. It shouldn't be just a representative. We should be looking for a place to meet that can accommodate all the people that can really impact.
Right.
Anyway, just
Well, in fairness, I agree with that totally. But that's what I said earlier about the issues with King County, and King County sees itself as this way. They don't think about. But the other piece here is that you, Evergreen, and Valley Medical, uniquely, are public hospital districts in King County, and you have responsibility for at least your district. We can talk about the service area beyond that, but at least your district. So there's a community, and that's a competency and a core value. You said it, you're part of your values and your mission and value that you bring to that table. But I agree with you. I don't think they get it even totally. But on the other hand, is why would they? They're about, when you put their value, their vision and mission up here, it talks about things like the best tertiary care in the whole world. It says just what you said, and keep the cost down.
so, we're working.
Right.
We'll get there.
Yeah. So assessment demonstrates that to be ready for the AAA, many rural hospitals show early signs of readiness for the future, but some face significant near-term challenges to sustainability. I know that doesn't sound like anything you thought of, does it? And hospitals will have to innovate their care model to, among other considerations, address primary care supply, cost management, evolving needs of the aging population, and the imperative transition from providing care to managing health.
That's a biggie, managing health.
Okay, providing care to managing health. That's a big part of the future. Scale is important, but integration will be critical in driving revenue and cost leadership to support sustainable margins at significantly reduced levels of reimbursement. So, and this is when you start thinking about, do we want to affiliate and what's the purpose of the affiliation and so on. Keep in mind, scale is important, and most big hospitals are trying to see how they can get bigger right now. So it is important because you can drive your unit cost down by spreading it further. But integration will be critical in driving revenue and cost leadership to support sustainable margins. So there's a distinction there between scale and integration. Yeah.
For me, that's a hard concept because healthcare is a very intimate, personal thing. And yet we're talking about big scale, integration. And I don't know that they necessarily blend together or mix.
No, I don't think you have to think about integration that way. I think that's the distinction they're trying to make. Scale versus just get bigger, which is just get bigger, versus integration, meaning that you connect the prevention and the primary care and the chronic care management so that you're really thinking horizontally, not vertically in terms of, is that what you'd say, Kim?
Yeah, and the conversation yesterday in finance committee about clinically integrated network.
Yes.
It's about integrating your care across a large network so that you get economies of scale, but it's not about just getting bigger for bigger's sake.
Roger, just a
What I found out is Kim had in her presentation, as part of our board presentation last time, we made a point, not to your person, but we made a point that you react out of fear and misinformation, but you respond out of planning and
the distinction between reacting and responding.
which I think is, we're beginning that process.
I agree. Gene, did I say something to offend you?
No, I just, my understanding was this was to end at 4.
Well, I saw that on one thing, and then I got an appointment that said it was 5, but I'll wrap up here quick anyway.
Oh,
I
no,
thought it was
if
gonna
you
be
want
done
to
by
say,
4.
if you're saying.
I'll
that's fine.
stay. Oh, yeah, I wouldn't quit until they start throwing me out, but I'll give Roger my wife's phone number.
To tag on to what Roger said and what I learned from the last strategic planning session is that you collect data and you do benchmarking, and that's really the most important thing that you do in the planning process. And I think only one person had quite a large percentage of that was Dr. Whitlock. And everybody else was like 5 or 10%. She was like 40%. That's what the reality is to learn what you have before you implement plan. Exactly. And so I did remember something.
Well, I guess maybe that's one of the takeaways I hope you get from this today too, is that I think we've got some really good nuggets, but almost all of this is going to have to go back and get processed and get moved ahead. There's got to be a commitment from you to work together as a team to do that. And it's got to get data. It's got to ground your assumptions. You've got to get the data. So to finish this, the AAA, rurals must understand community need and operate or arrange for services that support the high-volume community-based ambulatory and acute care needs. Operate or arrange for. For all other services, they should develop referrals to a regional delivery network of ambulatory, tertiary, quaternary, and post-acute care partners based on quality, cost, and proximity. Another way of saying what I said is you need to figure out what the whole system is and where you fit in it in a way that sustains you and you add value. Support patients in connecting, and then that's the other piece. And the other thing I would say is, we get people say, well, what about us? Will we chop liver here? You need to work with partners so that what ends up down the road, you're not there yet, but down the road, what gets marketed is the whole, you know, not the piece, not we do case management, come to us, or we do swing beds, come to us, but how does that fit in the whole?
The sum of it all.
Yeah.
Another thing I'd like to tap into what Gene said before about the extra costs of pushing people along to another entity, but I'd like to find out that data. What is the percentage of those people that come to the ER that go somewhere else in addition? And the median age who we serve. Those are two things that I think are
And we need more data on things like that and other things like how many patients are Medicare, how many are Medicaid, how many private pay, how many from the
Well, we
state.
do have that. We have that monthly. We have that monthly.
Okay, I want to get to something really important, and I sense that everybody's kind of beginning to get a little numb, I know I am, but I want to just finish these continual care centers for chronically ill. All of this needs to be balanced, but push of urban hospitals into rural communities. Can you say Swedish?
Yeah.
I mean, I remember when I started my time, there wasn't a Swedish Issaquah. To increase their referral footprints and help offset their revenue. So you're on that. You're aware of that. So this is one of the things I wanted to show you really quick, and it's a quick graphic, and it's in the handout, and I'm happy to talk more about it later. But another way to think about this whole thing is everybody needs the whole range of services, right? Everybody in your community is going to need those. And an urban or suburban medical center is going to, the red dot provides those services directly. Well, you see, they're going to provide almost all of them, right? All those services directly. Rural hospitals, mid-sized, some of them, and rurals, much more pushed down to the bottom. Now, you're even more unique because you're sort of rural and sort of not. But the point I'm trying to make here is it's not really about how do we figure out how to put the red dots in all the squares. It's about how does this whole thing get red dots in it from somebody somewhere and it fits together. That's the goal. So that's a graphic. Now, last thing I want to do, I want to share with you 2 examples of things, and they're just nifty ideas. One of them is, and I'm sure Roger knows about both of these, but I suspect you guys don't know too much about them. First, I'm going to talk about Verdant. Verdant Healthcare used to be Swedish Edmunds. I'm sorry, it used to be Stevens. I got ahead of myself. It used to be Stevens. When it was Stevens, not the entire team, it used to be Stevens. And when I worked at Evergreen, it was Stevens, and Stevens had a terrible reputation. And just about everybody talked about how, you know, they would never go to Stevens, and, you know, heard all that stuff on the streets, right? But frankly, their numbers were pretty good. Their quality was good. They didn't really have any bad situations. Their finances were reasonable, except they couldn't get volume because nobody wanted to go there. Because that's the word that got out. Who knows how it did? But they tried a lot of marketing. They got different CEOs, 3 of them, and they tried a whole different marketing. Nothing really worked. So then what they did was that the district commissioners leased the hospital to Swedish and got Swedish to pay them monthly, quarterly, or whatever, lease payments. Plus they retained their taxing business, and they created Verdant. And guess what happened for the community? As soon as the Swedish logo went up on the wall,
Everybody went.
their market share went up dramatically, and it stayed up. It's still up there. As Evergreen, there was no competition to speak of from Stevens back then. There is now. So that's that. But they also got their rent, their lease payments, plus their tax dollars. That's created this community network that's funds about $6 or $7 million a year, and this is still keeping stuff in reserve, specifically to do chronic care management, prevention, healthcare sustainability, and so on. So this isn't your model. I'm not saying you should do this model. I'm saying here's a group that thought out of the box, as Joan said, and actually thought about how do we do this differently. What that community got for the same money was much better, or at least perceived much better, acute care, and they got all this community health stuff, and they get people at their meetings, like 300 or 400 people come to these health things, and it's like the biggest thing since sliced bread there. It's just an amazing thing. Their community loves them. And just to give you a sense of this, and some of you talked about the press a couple times, when that transition first happened, the press was a little grumpy about, well, wait a minute, you mean we're paying taxes, but we're not even going to get the hospital? I mean, you could go there, right? And it's certainly true. We're going to pay, and that could have been an issue, but you know what? It's not an issue at all now. You know why? Because they're so successful, and they've been so great, and they love the whole arrangement, and the community's so engaged with them around the community piece, that whole argument went away. Now, there was literally a time for probably 6 months or 9 months there when there was kind of trying to dance around that, are we going to be able to deal with the taxpayers who say we shouldn't give this money? But what the taxpayers are really getting now for the same money is hugely better array of services. So that's just one idea. The other one I'm going to share with you, and one of you commented that, well, I can't do this yet because I have to advance my slides. One of you commented that, was there a mistake that Lincoln Hospital was on there? Nope, no mistake.
That's in Lincoln.
This is in
In
Davenport.
Oh.
No, Davenport.
Oh, Davenport.
Davenport, Washington.
Oh.
Davenport is,
So is-
yeah, I don't, no, that's it. That's as much as you get. That's just went to some other thing. I don't know if you got this thing. Okay, and Roger, you know, and some of you can know more about this, so jump in if you want to add something. But so Lincoln Hospital is about 60 miles from Spokane. And what I want you to look at here is this first paragraph. It's Davenport, it's the town. And Lincoln is the hospital, it's in Lincoln County. No, Lincoln City is in Oregon, and it's on the other side, right? The economic realities of a more competitive world and the nation's healthcare reform legislation after Obamacare have established new demands and expectations for all providers in healthcare. The The Affordable Care Act is ingrained within its principles like the person care, new payment and reimbursement methodologies based on performance rather than cost, and quality, patient satisfaction. These new demands and expectations imposed on all sizes of providers. Rural providers are being required to redefine their vision and capacities based on comparative performance with all other healthcare providers, including large hospital systems. So, what I want to find here is, he says in here, and I meant to highlight this and then I didn't, so I don't waste your time. But he says, so Lincoln's vision is to provide our community with access to the highest level of value in quality healthcare, wellness, and cost to optimize and restore their health. Note that this does not say provide services, rather it says provide access to care. This is significantly different than the traditional strategic planning approach that many rurals have taken in the past. Historically, communities look to build on ever-expanding and growing panel of services to raise revenue to build larger facilities and programs. The motto was grow or die. This slogan no longer fits the value-based equation that rurals must head under a reformed healthcare system. Must lead, I think that's like we're supposed to be. Now our slogan at Lincoln is, we are a good partner. We partner with anyone that brings value to our patients and to the people living in our county. We start from the recognition that others provide services that go beyond our capacity. We believe we add value to our patients by assuring them coordinated access to all of the services they need through the formal partnerships we form. Through these partnerships and collaborations, we look to build for our patients continued access to care at the local level and ensure their entry, etc. So this has been implemented.
Partner with anyone.
Right. That have that, not with anyone, but anyone that brings value to their community and to their patient, right, and to their hospital. Let me say about this that this isn't a pipe dream. He's done this. He's got this in place, and he's worked the relationship with big tertiary care hospitals, 2 of them in Spokane, and it works. He uses a robot for a number. Now it's not a robot like. Yeah, exactly. It's remote managed, right? So there's a video that some of you may have seen where of a person, I forgot what her diagnosis was. I think it was some orthopedic thing, but I can't remember what. And she's there with her primary care doc in the clinic in Davenport, and on real time, the orthopedist or specialist comes on and is able to be there, not random, but with the doctor there real time, and she's getting the care. She never has to leave. The other thing that this does is, as his initial stuff says, is it aligns with where the puck is going, because it really aligns with trying to maintain, putting the pieces together and keep people healthy. Now, one of the things, if we'd done this thing 5 years ago or 10 years ago, what you'd have found is, and you know this because this is how you make your money on swing beds, is that a while back, people would keep their patients. You'd send them, if you were this guy, you send them to Spokane for hip surgery. They'd say, you gotta come back to Spokane. You're really gonna give up the business if you're going to that puny little hospital over there. So they'd lose the patient. So there was a disincentive to even send them in the first place. So they ended into that silliness, right? Now, with the whole issue of we're gonna ding you for readmissions, and it's a lot cheaper to rehab at home, and by the way, research shows much more effective, then we're gonna work with you. But now, the flip of that is, Tom had to prove to these people who frankly didn't believe that rural hospitals were of sufficient quality to justify that, and maybe they were going to get their self in a tough place if they did that. So Tom had to prove and had to give me some metrics that showed that their quality was there and it was going to work and that the patient. So he's built that system. So it'd be great to talk to. I mean, yeah.
I think that's what's so important to appreciate is that it took Tom and his team, they've been working on this for the last 10 years.
Oh my, that's right.
So
That's right.
it's not an
That's right.
overnight project.
That's
at
right.
all.
That's exactly right. That's right.
I was just going to add, Ben, that he mentions in there the other collaborative program.
Yeah.
Critical Access Network. That we're heavily involved in our collaborative on the western side, and it's much more robust.
It is. It provides more services.
One of the things that we're looking at, and one of the things that we've found, we've looked at robots for 5 or 6 have found is that as a single rural hospital, we don't have much clout. And so through the collaborative, Dr. Whitcock is bringing the physician leadership in all of those hospitals up to the point that now we can look at a collaborative telemedicine remote care, remote specialty care project that now will have clout. Will be 13 hospitals that are now contracting for telemedicine and specialty care. So I just wanted to
No, that's really good.
It's
It's something, that's a really good point, and probably, we didn't have time anyway, but one thing I probably left out that was important is because you start thinking about what kind of relationships you want to have with people, there's a whole range of them, and it would be good. Some people use, in fact, the collaborative that he's talking about, really many of their members see that as a way to avoid formal, to get what you need, to keep costs down and be able to do something like a robot or sometimes sharing other things without either growing, which we don't want to do or couldn't do, or trying to necessarily affiliate in a formal way with somebody. You can do some of that by sort of virtual affiliation, and they can be through a collaborative, it can be through just partnerships with other people. But that's what I like about it, because that it's really a false assumption that the issue is sell out to Providence or go it alone. There's way many more options and possibilities.
Is there a need for that collaboration?
Yes, the Washington Rural Health Collaborative, right?
The west side or the east?
Whatever we're talking about.
Well, there's two. The one is the Washington, was the West, used to be called Western Washington, now it's called Washington Rural Health Collaborative.
Oh, that one I'm
And
aware
that's-
of. What's the other?
And the other one is the Critical Access Hospital Network. And Roger is absolutely right, that the former, the one that Roger's part of, and Kim are part of, does much more in the way of actual developing services and developing things that can be shared, either professions or services or whatever.
That's the 13 hospitals you were mentioning, Roger, is that right?
The Critical Access Hospital Network historically has been much more about trying to work together to find data systems and processes that will support them in moving forward. So they really have had a different kind of focus. But they're alike in the sense that they really see the collaboration as a way to do things they couldn't do by themselves or have to go join up with some big system.
And a lot of that is driving out costs for all of us, providing better care, and looking at sort of benchmarking our communities and moving into population health. So we're all moving toward that.
That's right, and that's maybe a good way to end, because the issue about all of this, if you're going to be successful going forward, has to do with two things. Well, three kind of money, but quality and data. And everybody who's thinking about moving to value, the whole conversation now is how do you prove data, value? And that's how you prove it is with quality. And how do you gather data to get quality? That's tough to do, but all right. Any questions or things that I should know or do or forgot about or something?
Ben, I'd like your thoughts on next steps.
What are the next steps?
Yeah.
That's it.
Oh, good.
Well, I think you should talk about that, and I think that's your conversation, the board's conversation with you informed by the staff. But I think that what I would say is you've got the SWOT. I think your idea of getting the engagement from the staff, broader conversations about that is a great idea. I think you can start use that. I would encourage all of you to be generous in your interpretations of what you say and hear and respond to, because you're going to get further faster if you do. So there's that. The second thing is, I think, doing some scenario planning. I think you're not there yet, but once you get a little better grasp on what your strengths and weaknesses are and what your core competencies are, and the urgency or not of the finance situation, I'll come back to that because I have an idea about that. Then I think you need to start saying, okay, so what's some scenarios? Let's say we don't know that, we know that these core competencies, finances, and so on, and what we know about the policies could be this. So critical access hospital changes could happen in 3 years. It's not going to happen sooner than 3, but it's probably not going to happen in 5 or 7. But then we're going to lay that out and we're going to say, okay, if that's the scenario, how would we respond? And how would we respond for the next, another scenario, and so on. So you're really not dealing with, I think of this kind of stuff we did today is sort of two-dimensional thinking. It's like, what's the facts, ma'am?
Yeah.
But you need to get to three-dimensional thinking, where you're thinking,
What if?
what would it look like if this were true?
Yeah, that's what Mr. Spivey was trying to
Yeah.
get at. How would we survive if this happened, if that happened?
But you first, well, not first, because it's iterative, you need to do it ongoingly, but you need to ground those assumptions with data, not just, common sense tells you that this would be a good idea, because common sense is not very helpful.
You know, we need the figures.
Dan, what do you know about sun-side, moving from a god to a people?
I don't know very much. John is an interesting fellow. I don't know very much. I know that the problem with cost-based reimbursement is it's both your best friend and your worst enemy. Because if you do things cheaper, you don't get paid as well. And on the other hand, it's also what keeps you going. So the CEO there, Gallagher, who doesn't have any love for cost-based reimbursement and really sees himself as being going out and taking on more and more situations, he's, I think, moving away from that.
I know that we're in a totally different market, totally different situation in terms of sole community provider. But I wonder if it would be instructive to the board to have someone from maybe John come over and talk to us about their thought process.
I think that might derail you, my personal opinion, because John has got a pretty, I mean, you should do whatever you want to do and have anybody talk, but I think having somebody like Tom, who's as of this weekend, Tom Martin, who's as of this weekend retired, has time on his hands, come over. That might be a good move. I think because of my personal opinion is, and having worked at Evergreen and done all this stuff in the nearby areas for much of my career, I think your future is something more like how do you integrate with the other folks that are here in a more powerful way. I know you do a lot of that now, but I don't think you really tapped that as far as you can. And I think they're not going away.
I'm sorry, what's not going on?
The Swedish.
Oh, I'm sorry, yeah.
Swedish, yeah. But I do think you can do some things they can't do, and I do think you can do some things that you not only they can't do well. I think you have you can nail the population health piece because you own it if you step up and take it. I mean, I think there's a whole bunch of stuff there where they would definitely partner with you, and so I think you should start looking at different models where linkages occur, and where the power is built on linkage. There's all kinds of examples, and there are ones where you stay totally the same, but you contract this out or contract that out. There are ones where you affiliate formally with other people, and there, so that doesn't matter. I mean, that's a legal question there. Not the legal. Anything else? Does that help for next steps? So scenario, data, drill down on the strengths and weaknesses, engage the community, the staff, community in that conversation.
Come back, what I heard come back with the strengths and weaknesses in a compilation.
Oh, yes, that's right. That's what I meant by lean in.
See things around that will inform that scenario plan.
Correct, exactly. You got to have that to go to the next step.
All right.
Compiled with some data.
Right.
Some of the things that we,
Yeah.
not a ton of stuff, but just some stuff that
Because
we can start out.
Because we can cast out,
Focus.
we can count out dozens of scenarios, but the data will inform us, well, which ones really have that.
That's that distinction between possibility and opportunity.
Opportunity, yeah. Okay.
Yeah.
All right. All right, guys. Thank you.
Thank
Hey,
you.
hey, Dan, I'm not a company of the board president will want to say this, but just as an individual here, I want to thank you for the fascinating and educational presentation.
Gee, thank you.
And I think we all gained a lot, but I'm sure the president would like to add something.
I'm sure she would too. You're not on the spot or anything, are you?
I know it's.
What's your speech?
Thank you. Let me just, since you said that, Gina, that really did mean a lot, and Gerald and I have been working to try to make sure it was the right stuff. So I've said this before, and some of you have heard me say it, but it's from the heart. You guys, the reason I sometimes talk with commissioners, elected public board members, is because I think it's really all about you. You're the nexus between the community and the health system. And that's why I like the public hospital district system. But then that kind of takes with it some responsibility, to move in some different directions, to take that leadership, to be engaging, but at the same time, move it ahead. At the end of the day, I don't know, I know you've had somewhat of a checkered past in this hospital, because I was at Evergreen and some of this stuff over there. But how long would you say, I mean, how long has there been some kind of hospital or health system out in this area?
30 years.
Oh, no, 72 is when it was a hospital district, and, when it actually became a hospital district, so it's,
They built the hospital in 81 or 82.
Right,
well, we had Nels before that.
that's right, that's right. Now,
We had Ellis Hospital before that.
So,
His wife was born there.
Wife was born.
so that's
She
good.
was
Wow.
But let me just say that, when you think about that, it's a legacy issue.
It is.
Absolutely.
And when, in 80 years from now, will there still be the right system there for the people that need it then? And if you think I'm being a little overstated, I'm not, because if people didn't address these same kind of challenges 40, 50, 60 years ago, we wouldn't have this meeting because there wouldn't be anybody here to have it.
Things are moving so fast, the question may be in 8 years.
Well, there you go, that's right. All right, thanks, guys.
Thank you.
You guys-
See you.